The discipline and practice of nursing have evolved from task-oriented functions into a professional field requiring advanced judgment, technical expertise, and holistic patient care. In the 19th century, Florence Nightingale emphasized sanitation, organization, and the role of environment in recovery, setting the foundation for modern nursing. Over time, the profession expanded to integrate both scientific and interpersonal approaches, balancing compassionate care with evidence-based practice. Today, nursing is shaped by technological integration, including electronic health records and telehealth, while also facing persistent workforce shortages and growing educational requirements. Emphasis on self-care within the profession highlights the recognition that the well-being of nurses directly affects patient outcomes. The dual identity of nursing as both an art and a science reflects its unique position in healthcare, requiring technical competence alongside interpersonal skill and ethical grounding. Nursing education is structured in a tiered manner to accommodate different roles and responsibilities. Practical nursing programs prepare licensed practical nurses and licensed vocational nurses in 12 to 18 months of training, equipping them for tasks such as medication administration and wound care under supervision. Associate degree programs in nursing, typically 2 years in length, expand on these skills and prepare registered nurses with competencies in patient assessment, care planning, and independent clinical judgment. Bachelor of Science in Nursing programs, lasting about 4 years, provide broader preparation in clinical practice, leadership, public health, and research, reflecting the increasing complexity of healthcare delivery. The bachelor's degree has become the preferred entry point into professional nursing, supported by evidence linking higher education levels with improved patient outcomes and career flexibility. Graduate education through Master of Science in Nursing and doctoral degrees, whether practice-focused as in the Doctor of Nursing Practice or research-focused as in the Doctor of Philosophy, enables nurses to move into advanced clinical practice, leadership, education, and research. The American Association of Colleges of Nursing codifies expected competencies across these levels in the Essentials, providing a national standard for nursing education. Licensure serves as a safeguard for patient care by ensuring that only qualified individuals practice nursing. Regulatory bodies such as state boards of nursing determine requirements for practice and administer examinations that assess readiness. The process enforces baseline competencies while supporting the development of specialized expertise through certifications in fields like critical care, pediatrics, or oncology. Continuing education requirements sustain lifelong learning, aligning nursing practice with new evidence, updated standards, and emerging technologies. By linking education, examination, and regulation, licensure ensures that professional accountability and public trust remain central to nursing practice. The scope of practice defines the legal and professional boundaries for nurses, shaped by jurisdictional regulations and professional organizations. State boards of nursing establish detailed rules regarding what tasks and responsibilities are permitted, while national and international groups set broader standards that emphasize autonomy, collaboration, and advocacy. The American Nurses Association outlines expectations in its scope and standards of practice, while the International Council of Nurses articulates a global perspective on professional values and ethical responsibilities. Within these frameworks, nurses are authorized to perform assessments, develop care plans, administer medications, coordinate care, educate patients, and advocate for health equity. Variations exist across states and countries, but the underlying principle is that scope reflects preparation, competence, and professional responsibility. Standards of nursing practice encompass codes of ethics, professional conduct, and quality expectations. The Code of Ethics centers care around dignity, safety, and respect for patients, while also mandating professional accountability. Initiatives such as the Quality and Safety Education for Nurses project influence curricula by emphasizing person-centered care, teamwork, evidence-based practice, quality improvement, safety, and informatics. Although not regulatory, these competencies shape both education and practice, guiding how nurses adapt to evolving health systems. Together, standards and competencies form a framework for ethical decision-making, clinical safety, and professional development. Nursing roles are diverse and multifaceted, extending beyond bedside care. As caregivers, nurses deliver comprehensive interventions, addressing physical, psychological, and social needs. Clinical decision-making involves prioritizing patient care, interpreting data, and adapting to changing conditions. In managing care, nurses coordinate multidisciplinary teams, allocate resources, and ensure continuity across settings. Communication underpins every function, enabling patient education, interprofessional collaboration, and effective advocacy. Advocacy extends from protecting individual patients' rights to influencing systemic policies that shape equitable access to healthcare. Educational roles involve translating complex health information into accessible guidance for patients and communities, supporting prevention and self-management of illness. Each of these roles is interconnected, reinforcing the centrality of nursing in the healthcare system. Theoretical frameworks provide structure to nursing practice, guiding how nurses conceptualize and deliver care. Florence Nightingale's environmental theory emphasized the influence of clean air, water, and surroundings on health. Hildegard Peplau highlighted the therapeutic nurse-patient relationship, while Virginia Henderson defined nursing as assistance with activities that support independence. Jean Watson emphasized human caring as a moral and scientific foundation, and Madeline Leininger advanced cultural care theory, addressing the role of cultural context in health. Patricia Benner's novice to expert model describes stages of professional growth, and Dorothea Orum's self-care deficit theory frames nursing as support for individuals unable to meet their own needs. These theories draw from psychology, sociology, and biology, underscoring the interdisciplinary foundation of nursing knowledge. Communication in nursing encompasses multiple forms and levels, each of which plays a critical role in ensuring safe and effective patient care. Nurses must establish trust through consistent, empathetic, and professional communication, aligning verbal messages with nonverbal cues to avoid incongruence. Written and electronic communication are also integral components, and attention must be paid to patient preferences regarding these modes. Communication in nursing is often categorized into 4 levels: intrapersonal, interpersonal, small group, and public. Intrapersonal communication involves self-reflection, which supports growth and improvement in practice. Interpersonal and small group communication occur frequently during patient care, facilitating coordination, teamwork, and patient safety. Public communication allows nurses to extend their impact beyond individual encounters by disseminating research and advancing health education at the community or institutional level. Various communication models guide interactions depending on the context. The transmission model represents a linear, one-directional flow of information, and is suited for situations in which feedback is not expected, such as pre-surgical instructions. The interactional model allows two-way communication, with feedback provided between participants, making it useful for discharge teaching or follow-up care. The transactional model views communication as a dynamic process in which participants simultaneously send and receive messages while building relationships, which is valuable when sharing research findings with professional audiences or collaborating with colleagues. Recognizing which model applies in a given situation ensures that communication is efficient, appropriate, and effective in meeting its purpose. In clinical settings, communication must be clear, factual, concise, and purposeful. Professional communication builds trust between patients and providers and must be rooted in courtesy, empathy, and respect. This trust enhances patient compliance and encourages the adoption of healthier behaviors. Motivational interviewing is one structured approach that nurses and healthcare professionals use to support behavioral change. It is based on engaging with patients, focusing on specific goals, evoking the patient's own motivations, and planning actionable steps. This method integrates empathetic and collaborative communication with a goal-oriented structure, reinforcing patient autonomy while guiding progress toward improved health outcomes. Therapeutic communication is central to nursing practice, providing patients with a supportive environment to express themselves openly. Techniques include the use of open-ended questions, active listening, and respectful dialogue. These practices encourage patient engagement and allow for deeper understanding of concerns and needs. A feedback loop is essential for evaluating the effectiveness of therapeutic communication, helping nurses refine their approach over time. Conversely, non-therapeutic techniques, such as interrupting, dismissing concerns, or using judgmental language, should be avoided, as they inhibit dialogue and erode trust. Barriers to communication are common in healthcare environments and must be actively identified and addressed by nurses. Environmental factors such as noise, interruptions, or physical layout can disrupt communication, while personal factors such as stress or cultural differences may also interfere. Emotional intelligence, including self-awareness and self-management, enhances a nurse's ability to navigate these barriers effectively. By recognizing their own emotions and regulating responses, nurses can create a more open and constructive environment for communication. Because nurses often serve as the primary link between patients and the broader healthcare team. Their ability to anticipate, identify, and overcome barriers ensures more comprehensive and satisfactory care. Addressing communication challenges directly improves patient safety, strengthens trust, and supports positive health outcomes. Patients encounter care at 3 levels within the healthcare system. Primary care provides preventive and routine services, such as screenings, immunizations, wellness visits, and treatment of common illnesses. When patients require specialized knowledge, procedures, or diagnostics, they enter secondary care, which is delivered in hospitals, specialty clinics, and therapeutic facilities by professionals with advanced training. Tertiary care addresses the most complex or critical needs, including trauma, extensive surgeries, rare diseases, and intensive treatments, typically in large hospitals or specialized centers, such as dialysis or addiction treatment facilities. Healthcare systems can be classified by their structure and function. Economically, they may operate as for-profit, not-for-profit, or government-funded institutions. They can also be described as public or private, depending on management and financing. Integrated systems are organized to coordinate services across facilities and providers, improving continuity of care. Barriers to access exist at all levels. Geographic distance, transportation, scheduling constraints, and provider shortages can limit care. Financial barriers affect both insured and uninsured patients, while disparities in education, health literacy, cultural background, and systemic inequities further restrict access. Mistrust of medical institutions also contributes to avoidance or delay of treatment. Healthcare culture has shifted from discipline-centered, disease-focused models toward collaboration, patient-centeredness, and holistic care. These changes emphasize communication across professions, shared responsibility, and recognition of social and psychological factors in health. Alongside this shift has been an increased emphasis on safety and continuous quality improvement, replacing a blame-oriented culture with one focused on systems planning, management, and learning. Health is defined as a state of complete physical, mental, and social well-being, not merely the absence of disease. Wellness is the active pursuit of choices and behaviors that foster holistic health. Human dimensions of health include physical, emotional, social, intellectual, and spiritual aspects, while wellness is often described in 8 interconnected dimensions: physical, emotional, social, occupational, spiritual, intellectual, environmental, and financial. Dunn's theory of wellness emphasizes the processes of being, belonging, becoming, and befitting. In the United States, the Healthy People 2030 initiative sets national objectives to improve population health, focusing on disease prevention and addressing social determinants of health, which include economic stability, healthcare access and quality, education, the built environment, and social context. These determinants shape health disparities and highlight the need for policies that promote equity and access to community-based care. Models of health provide frameworks for understanding patient needs and guiding care. The health belief model, health promotion model, holistic health model, and Maslow's hierarchy of needs are used in nursing to assess risks, prioritize care, and evaluate outcomes. Broader medical models such as religious, humanistic, and transpersonal frameworks add perspectives on illness and meaning. Biomedical, psychosomatic, and existential models explain health behaviors and responses to disease. Together, these approaches recognize the interaction of biological, psychological, social, and environmental factors, supporting holistic care. Health promotion strategies operate at global and individual levels. Policies that encourage healthy behaviors, supportive environments, community engagement, and personal skill development all contribute to improved outcomes. Primary prevention prevents disease through risk reduction and lifestyle change. Secondary prevention targets early detection and prompt treatment. And tertiary prevention reduces the long-term impact of disease through rehabilitation and ongoing management. Effective application requires identifying risk factors such as genetics, lifestyle, or environment, and tailoring interventions accordingly. Illness influences health promotion by altering behavior, self-concept, and family dynamics. But proper management and support can help mitigate negative effects and improve well-being. Nurses are central to community-based health care, functioning as educators, caregivers, collaborators, counselors, advocates, and change agents. Their responsibilities include promoting healthy lifestyles, preventing disease, teaching communities, and evaluating outcomes. They work with diverse and at-risk groups, including individuals with disabilities, children, older adults, underrepresented populations, the uninsured, and those with limited financial resources. Addressing disparities within these populations requires cultural competence, advocacy, and evidence-based practice. Community health initiatives rely on active involvement, stakeholder engagement, and long-term sustainability. Community health needs assessments identify priorities, and tools such as the CDC Community Health Status Indicators and the Vulnerable Populations Footprint provide data for planning. Nurses contribute by managing resources, providing education, and ensuring interventions are culturally appropriate and evidence-based. Planning requires problem prioritization, goal setting, implementation of strategies, and outcome evaluation to ensure effectiveness. Population health management addresses health at the systems level. Its focus includes population involvement, improvement of health outcomes, analysis of health determinants, and revision of policies to reduce disparities. Goals include better clinical outcomes, coordinated care across services, and targeted management of chronic and complex conditions. Nurses contribute as primary care partners, coordinators, facilitators, and informatics specialists, connecting patients with care and addressing social determinants. Through these roles, they advance equity, support community resilience, and improve outcomes for diverse populations. Culture consists of the shared beliefs, values, attitudes, and practices of a group that are learned, accepted, and passed on through generations. Cultural background influences how individuals perceive health and illness, their expectations of providers, and their willingness to follow treatment plans. Culture also shapes who receives care and the quality of that care, with certain groups experiencing higher disease burdens due to genetic predispositions or disparities linked to socioeconomic factors. Many cultures maintain traditional healing practices that may be used alongside or instead of Western medicine. Nurses frequently care for patients whose cultural beliefs differ from their own, making it essential to remain aware of explicit and implicit biases in order to provide equitable and respectful care. Culturally competent practice requires cultural humility, which involves acknowledging the limits of one's own perspective and seeking input from reliable cultural sources. Nurses use cultural negotiation to balance respect for patient traditions with safe and effective care. Exposure to diverse cultural practices, whether through patient interaction, historical study, or direct participation in cultural events, helps nurses develop awareness and reduce personal biases. Responsiveness to cultural diversity means accommodating patient preferences where possible and adjusting care in ways that maintain safety while honoring individual values. A cultural assessment is a necessary step in care planning for patients from diverse backgrounds. The Transcultural Nursing Society has established standards of practice for culturally competent nursing care that guide nurses in delivering equitable and safe care. These standards highlight the influence of 6 cultural phenomena: communication, space, social organization, time orientation, environmental control, and biological variation. Awareness of these factors helps nurses identify areas where bias may interfere with care and adjust practices to improve inclusivity. Efforts to provide equitable care must address health equity and disparities. Nurses must remain alert to inequalities within populations and work to foster respect, understanding, and collaboration. Barriers to cultural competence include stereotyping, cultural imposition, cultural blindness, and cultural conflict. Communication barriers such as language differences, low health literacy, and lack of accessible services compound these issues. Nurses who actively address these barriers contribute to more inclusive care environments and better health outcomes for diverse patient populations. Values form the foundation of both personal conduct and professional nursing practice. They are shaped by family, religion, education, professional training, and cultural environment. Core nursing values include altruism, autonomy, integrity, social justice, and human dignity, and these principles are embedded in the nursing process itself. They guide patient interactions, clinical decisions, and professional behavior, ensuring that nursing remains focused on both individual and collective well-being. Ethics are inseparable from nursing practice, providing the framework through which values are applied in clinical care. The Code of Ethics for Nurses sets professional standards and serves as a reference throughout a nurse's career, regardless of role or setting. Ethical principles such as autonomy, justice, and veracity must inform decision-making in all patient encounters. Ethical theories further shape nursing practice. Deontology emphasizes the inherent rightness or wrongness of actions, while utilitarianism emphasizes outcomes and the greatest good for the greatest number. Care-based ethics focuses on relationships and responsibilities, and feminist ethics challenges systemic inequities and advances social justice. Because the most ethical course of action is not always obvious, nurses may experience moral distress. Structured approaches such as the MORAL model and the Four Topics method provide strategies to analyze dilemmas and support consistent, principled decision-making. Nurses must also navigate the legal framework that governs practice. State Nurse Practice Acts, enforced by state boards of nursing, define scope of practice, licensure requirements, and professional responsibilities. Compliance with these laws protects both patients and providers, while violations may lead to disciplinary action or legal liability. Nurses must be familiar with regulations tied to their education, certification, and licensure, as well as the potential for legal action in the form of criminal charges or tort claims. Protecting oneself legally requires adherence to standards of care, documentation, and avoidance of fraudulent or harmful practices. Advocacy is a professional responsibility that extends to patients, colleagues, and public health. Nurses occupy a unique position of influence due to their numbers and proximity to patients. Advocacy can occur on multiple levels, from direct patient support at the bedside to participation in health policy discussions at national forums. Barriers such as time constraints, lack of institutional support, fear of repercussions, and patient-related complexities may hinder advocacy efforts. Despite these challenges, effective advocacy remains essential for advancing health equity, improving systems of care, and upholding the rights and dignity of patients. Vital signs are fundamental indicators of physiological stability and are routinely measured because they reflect the body's ability to maintain homeostasis. Temperature, pulse, respirations, blood pressure, and oxygen saturation are interrelated, and deviations in one may signal disruptions in another. Temperature is regulated by the hypothalamus through mechanisms such as sweating and shivering to restore balance. Pulse reflects cardiac function and circulatory efficiency, with rate and rhythm serving as indicators of cardiovascular status. Respirations provide oxygen and remove carbon dioxide, maintaining gas exchange in the lungs. Blood pressure represents the force exerted by circulating blood on arterial walls, essential for perfusion of tissues and organs. Oxygen saturation measures the percentage of hemoglobin carrying oxygen, offering insight into respiratory and circulatory effectiveness. Together, these measures allow providers to assess health status quickly and accurately. Accurate measurement of vital signs is a core nursing responsibility. Temperature can be obtained orally, tympanically, axillary, or rectally, with route selection based on age, condition, and clinical setting. Pulse is palpated manually at designated pulse points using the index and middle fingers, with care taken to apply consistent but gentle pressure. Respirations must be assessed unobtrusively, as patients may alter breathing patterns if they are aware of observation. Oxygen saturation is measured with a pulse oximeter, most often on the finger but also on the earlobe or forehead if necessary. Blood pressure measurement may be conducted manually with a cuff and stethoscope, automatically with an electronic device, invasively with an arterial line, or through continuous non-invasive monitoring, with the method selected according to patient needs and acuity. Patients may also be expected to monitor their vital signs outside of clinical settings. Nurses play a critical role in teaching patients how to perform these measurements reliably, tailoring instruction to individual learning preferences. Education includes correct use of equipment, recognition of normal ranges, and steps to confirm or troubleshoot abnormal readings. Patients must also understand when and how to communicate abnormal findings to their healthcare team to ensure timely intervention. Admissions to healthcare facilities vary in type and purpose, and selecting the appropriate level of care is critical. Acute care admissions are designated for patients requiring close inpatient monitoring or advanced professional services, while observational admissions are generally short stays of 1 or 2 nights. Admissions may be planned, such as scheduled procedures, or unplanned, as in emergencies from home, ambulatory clinics, or arrival via emergency medical services. The admitting nurse plays a central role in initiating safe and effective care. Responsibilities include receiving a complete and accurate handoff report, ensuring current patients remain safe, notifying co-workers of the incoming admission, and preparing the room to meet the patient's individual needs. Organization and clear communication are essential to maintain safety during this transition. Establishing rapport early promotes informed decision-making, while orienting the patient to the facility and routines fosters comfort, safety, and engagement in their care. Transfers represent another critical transition point and can occur within a facility or between facilities. Transfers to higher levels of care, such as intensive or specialty units, differ in focus from those to extended care or rehabilitation facilities. Nurses ensure that reports highlight the information most relevant to the patient's new level of care, while maintaining complete documentation in the medical record. Collaboration among the healthcare team is essential to guarantee accuracy, continuity, and safety during transfers. Discharge planning begins upon admission and continues throughout the hospital stay. Early goal setting engages the interdisciplinary team and ensures that physical, medical, psychosocial, and educational needs are addressed. A comprehensive discharge plan requires patient and family education, resource coordination, and tailored interventions that support a safe transition out of the facility. Some patients may choose to leave against medical advice, requiring education on potential risks and thorough documentation of the event. Reasons for AMA discharge are varied and often rooted in personal or socioeconomic obligations rather than refusal of care. Discharge from home health agencies follows similar principles, requiring demonstration that goals have been achieved or substantially progressed, and that services are no longer necessary. Across all settings, clear patient education and precise documentation are fundamental to successful discharge and continuity of care. Patient safety is a central responsibility of nursing and must be prioritized in all care settings. Nurses evaluate individual risk factors such as developmental stage, physical condition, psychosocial health, and knowledge deficits to anticipate and prevent harm. Maslow's hierarchy of needs can be applied to prioritize safety within the broader context of patient care. Environmental hazards are also considered, including risks related to falls, fires, poisoning, suffocation, exposure to toxic substances, and weather extremes such as hypothermia. Occupational safety measures are required to protect both patients and healthcare workers from injury or illness, highlighting the interconnectedness of personal, environmental, and workplace safety. A just culture supports safety within healthcare organizations by promoting learning from errors without fear of punishment. This approach allows both individual providers and institutions to identify the causes of mistakes, address system weaknesses, and implement strategies that prevent recurrence. By fostering transparency and accountability, just culture reduces the risk of adverse events, near misses, and preventable harm. Nurses also provide patient and community education related to safety. Social determinants of health strongly influence individual risk, as barriers such as lack of clean water, food, shelter, financial resources, or healthcare access increase vulnerability. Disparities based on socioeconomic status, age, gender, ethnicity, and mental health status must be recognized when developing safety-focused care plans. Abuse is a significant safety issue across the lifespan and requires careful assessment. Nurses must be able to identify signs of physical, psychological, financial, and substance-related abuse. Prompt reporting and intervention are mandated when abuse is suspected or confirmed. Family violence, including intimate partner, child, and elder abuse, often comes to light during nursing assessments in primary care, hospital, or community settings, placing nurses in a critical position to identify, document, and address these concerns. Social violence presents additional risks to safety and health. This category includes bullying, incivility, workplace violence, and human trafficking. Nurses address these issues by recognizing signs, advocating for systemic change, and connecting affected individuals with resources such as counseling and mental health care. Broader interventions include advocating for policies that reduce access to weapons and addressing underlying causes such as poverty, discrimination, and inequality. Nurses in schools and community settings are particularly positioned to intervene, offering assessment, support, and advocacy tailored to victims' needs. Technology plays a growing role in patient safety. Electronic health records facilitate accurate information sharing, improve care coordination, and provide patients with greater access to their own health information. However, these advancements require strict attention to privacy and data protection. Nursing informatics has emerged as both a specialty and a core competency, as nurses must be able to integrate technology into practice safely and effectively. Emerging technologies such as artificial intelligence further challenge nurses to adapt while maintaining the standards of confidentiality, accuracy, and patient-centered care. Infection prevention and control require a clear understanding of how infections develop and spread. The chain of infection consists of 6 elements: causative agent, reservoir, portal of exit, mode of transmission, portal of entry, and susceptible host. An infection can only occur if all 6 are present, and breaking the chain at any point interrupts transmission. Nurses must be able to recognize signs and symptoms of infection through physical assessment, patient history, and review of records. The immune system provides protection against pathogens through non-specific defenses, such as inflammation and skin barriers, and specific responses, such as antibody production, which target particular pathogens with precision. Recognizing these mechanisms assists nurses in identifying infection and supporting appropriate interventions. Aseptic practice is central to infection control. Medical asepsis, or clean technique, minimizes the spread of pathogens in everyday care, while surgical asepsis, or sterile technique, eliminates all microorganisms in invasive procedures. Nurses must select and properly use personal protective equipment based on the risk of exposure and the nature of care provided. Healthcare-associated infections are a major concern and often linked to invasive devices. Common HAIs include catheter-associated urinary tract infections, central line-associated bloodstream infections, ventilator-associated pneumonia, and surgical site infections. These conditions extend hospital stays, complicate treatment, and increase patient morbidity. Environmental hygiene significantly influences infection control. Contaminated surfaces and equipment are frequent sources of transmission, making thorough cleaning and strict adherence to protocols essential. Nurses must understand the distinctions between sanitization, disinfection, and sterilization, and apply these processes as appropriate. Competence in sterile technique is critical to patient safety, particularly in operative and procedural settings. Standard precautions, including consistent hand hygiene and appropriate PPE use, apply to all patient care. When patients present with known or suspected infectious diseases, transmission-based precautions, contact, droplet, or airborne, are implemented to provide additional protection. Nurses also play an advocacy role, ensuring that institutional policies align with evidence-based practices and that staff receive adequate training in infection control, sharp safety, and exposure reduction. Special attention is required in the use of antibiotics, as overuse or misuse contributes to multi-drug-resistant organisms. Nurses must educate patients about proper antibiotic use to reduce resistance and improve outcomes. Through consistent application of infection control principles, combined with patient and staff education, nurses serve as the frontline defense against the spread of infection within healthcare facilities and the community. Medication orders are issued in several forms, each with distinct purposes for safe and effective patient care. Routine orders are administered on a regular schedule until discontinued, while one-time orders authorize a single dose. Standing orders permit nurses to act without waiting for direct provider input in specific circumstances. STAT orders are reserved for urgent situations requiring immediate administration. PRN orders, or as-needed prescriptions, address symptoms such as pain or nausea when they arise, and titration orders allow for incremental dose adjustments based on clinical response. A complete medication order must contain clear patient identifiers, such as name and date of birth, along with drug name, dosage, route, frequency, and timing of administration. It also requires the date and time of issuance and the prescriber's signature to ensure legality, authenticity, and accountability. Any missing or ambiguous elements increase the risk of error and compromise patient safety. Medication safety is achieved through strict adherence to verification and monitoring practices. Correct patient identification, double-checking orders, and maintaining an environment free of distractions are essential. Nurses must monitor for adverse drug reactions, which may result from individual factors such as age, sex, genetic predisposition, or comorbidities. Severe allergic responses, including anaphylaxis, demand immediate intervention, while drug toxicity from accumulation requires prompt recognition and treatment. Tolerance, paradoxical effects, and interactions between medications or with food further complicate drug therapy and necessitate vigilant monitoring. Collaborative oversight from nurses, pharmacists, and prescribers establishes multiple safety checkpoints. Guidelines from organizations such as the Institute for Safe Medication Practices and the Joint Commission support these practices by providing standards, restricted abbreviation lists, and high-alert drug classifications. The rights of medication administration form the foundation of nursing responsibility. Traditionally, these include the right patient, drug, dose, route, and time. The American Nurses Association has expanded them to include the right reason, documentation, and response, ensuring both safety and accountability. Barcode medication administration systems reinforce these principles by using electronic verification at the point of care. In addition, nurses must review patient histories, assess for contraindications, provide education, and respect the right of refusal. Medication can be delivered through multiple routes, each requiring precise technique. Oral administration involves tablets or liquids, proper patient positioning, and confirmation of swallowing. Intradermal injections, used for allergy or tuberculosis testing, involve shallow insertion and wheal formation. Subcutaneous injections, such as insulin, require site rotation and careful technique to minimize tissue damage. Intramuscular injections demand appropriate muscle selection, needle choice, and aspiration to avoid vascular injury. Intravenous administration allows for immediate systemic effect, but requires strict asepsis and continuous monitoring for complications. Ophthalmic, otic, nasal, inhalation, vaginal, and rectal routes necessitate careful hygiene, correct positioning, and patient comfort to ensure effective absorption and minimal adverse effects. Nurses are responsible for safe medication management at every stage. This includes pre-administration assessments such as vital signs, allergies, or swallowing ability, careful delegation to appropriate personnel, accurate documentation of doses and responses, and evaluation of therapeutic effect. Patient education on the purpose, use, and potential side effects of medications fosters adherence and safety. Finally, error reporting is an essential professional duty, supporting continuous quality improvement and preventing recurrence of mistakes. Nursing assessment is a systematic and comprehensive process used to gather accurate information about a patient's health status, encompassing not only physical signs, but also psychosocial, emotional, and spiritual factors. This holistic approach allows care to be tailored to individual needs. The assessment begins with evaluating the patient's current condition, identifying risks or changes, and prioritizing health concerns that require intervention. The accuracy of this process is critical, as it forms the foundation for diagnosis, care planning, and treatment. Different types of assessments are performed depending on the clinical situation. The initial assessment is the most complete, conducted on admission to establish a baseline database that guides all future care. Problem-focused assessments are narrower in scope, targeting specific issues or monitoring chronic conditions. Emergency assessments are rapid and concentrated on life-threatening problems that require immediate stabilization. Time-lapsed assessments occur after extended intervals, often months, to evaluate long-term progress or the effectiveness of interventions. Ongoing assessments are continuous throughout care, ensuring deviations from baseline are identified promptly and guiding adjustments in treatment. Data collection in nursing assessment involves multiple sources, including the patient, family members, observations, and healthcare records. Techniques include observation, communication, inspection, auscultation, palpation, and percussion, all of which provide a detailed picture of health status. Once collected, the nurse prioritizes patient needs using frameworks such as the ABCS, airway, breathing, circulation, and Maslow's hierarchy of needs, addressing the most urgent and fundamental issues before broader concerns. The data are then analyzed through recognition of patterns, reasoning, and interpretation of clues. Critical thinking, clinical reasoning, and clinical judgment are essential cognitive processes in this stage. Critical thinking involves questioning and evaluating information systematically, while clinical reasoning is the step-by-step process of gathering cues, processing data, identifying problems, and planning interventions. Clinical judgment is the culmination of these skills, requiring the nurse to synthesize all available information, including history, examination findings, and prior knowledge, to make decisions about patient care. Nursing diagnosis is a defining element of professional nursing practice, distinguishing it from medicine by focusing on patient responses rather than disease pathology. It is supported by the ANA standards of practice and competencies for nursing diagnosis, which emphasize the role of clinical judgment in guiding nursing care. This approach reflects the problem-solving foundation of nursing and affirms the profession's autonomy. NANDA International, NANDA-I, provides standardized taxonomy and classification to ensure clear and consistent communication of nursing diagnoses. Tanner's clinical judgment model offers a framework for decision-making that emphasizes noticing, interpreting, responding, and reflecting. More recently, the clinical judgment and measurement model has been introduced, integrating 6 cognitive skills with the nursing process to strengthen critical thinking and align with evolving patient needs. These models differ slightly in perspective, but all reinforce structured reasoning for effective care planning. Clinical decision-making in nursing is guided by the steps of predicting, preventing, managing, and promoting. This framework supports accurate diagnosis and helps nurses understand the rationale behind their judgments. Nursing diagnoses differ fundamentally from medical diagnoses. Medical diagnoses identify disease processes, while nursing diagnoses address patient responses to illness or life circumstances. Outcomes are measured against expected versus actual results, and adjustments are made as needed to maintain alignment with patient goals. SMART goals, specific, measurable, attainable, relevant, and time-based, provide a structured method to ensure that goals are realistic and achievable. Nanda I organizes nursing diagnoses into 4 categories: problem-focused, risk, health promotion, and syndrome. Once a category is selected, the nurse validates the diagnosis by comparing assessment findings with evidence-based standards. Re-examination of data ensures that the diagnosis accurately reflects the patient's condition. If outcomes are not met, or the patient's status changes, the diagnosis may be redefined or replaced to better address current needs. This iterative process allows flexibility and responsiveness in patient care. The planning phase builds on diagnosis by organizing and prioritizing patient needs using evidence-based resources such as clinical pathways and core measures, frameworks including the ABCs, Maslow's hierarchy, and distinctions between acute versus chronic or actual versus potential problems guide prioritization. Goals may be short or long-term, but must remain specific and realistic. Nurses serve as coordinators of care during this phase, ensuring collaboration across disciplines, educating patients and families, and maintaining clear communication. Effective planning ensures that interventions are purposeful and outcome-driven, with patient safety and well-being at the center of decision-making. The implementation phase of the nursing process is the stage in which planned interventions are actively carried out to address patient needs. Nurses apply clinical knowledge and technical skills to deliver both direct and indirect care, ranging from administering medications and performing procedures to coordinating services and providing education. Because patient conditions are rarely static, interventions must be flexible and adapted to ongoing changes. Continuous monitoring ensures that interventions remain effective and aligned with the patient's evolving health status. This phase demands integration of psychomotor skills for precise execution, cognitive skills for decision-making, and interpersonal skills for effective communication with patients, families, and interdisciplinary teams. Interventions in nursing practice are classified according to the level of responsibility and collaboration required. Independent interventions are nurse-initiated actions such as patient education or positioning for comfort. Dependent interventions are carried out under a provider's order, including medication administration or treatments. Interdependent interventions require collaboration with other professionals, such as coordinating physical therapy or dietary modifications. Direct interventions focus on the patient directly, while indirect interventions support care through activities like documentation, resource management, and interprofessional communication. Prioritization frameworks such as the airway, breathing, circulation model, and Maslow's hierarchy guide the sequence in which interventions are implemented, ensuring urgent and life-sustaining needs are addressed first. Effective delegation to qualified personnel and seamless teamwork with other healthcare providers further strengthens safe and efficient implementation. The evaluation phase follows naturally, as every intervention must be assessed for its effectiveness in meeting patient outcomes. Documentation is central to this process, providing a precise record of patient responses and guiding future decision-making. Documentation serves as a communication tool among providers, a legal safeguard for nursing practice, and a means of ensuring continuity of care. Records must be comprehensive, accurate, timely, and written in standardized terminology. They should detail assessments, interventions, changes in condition, patient education, and responses to treatment. using recognized frameworks such as SOAP, Subjective Objective Assessment Plan, PIE, Problem, Intervention, Evaluation, or charting by exception ensures organization and clarity. Documentation must remain professional, focusing solely on patient care rather than interpersonal conflicts, and should incorporate approved abbreviations and clinical language. Evaluation also integrates quality assurance and quality improvement processes. Quality assurance programs assess whether healthcare structures, processes, and outcomes align with established standards. Quality improvement initiatives go further by analyzing data to identify inefficiencies and implementing strategies for safer, more effective, and patient-centered care. Nursing-sensitive indicators such as falls, pressure injuries, and infection rates provide measurable outcomes to evaluate nursing performance. Databases such as the National Database of Nursing Quality Indicators allow hospitals to benchmark performance and implement evidence-based changes. Patient satisfaction surveys, such as HCAHPS, contribute additional insights by highlighting the patient's perspective on care delivery. Research has been embedded in nursing since the work of Florence Nightingale, who used systematic observation and statistical analysis to improve patient outcomes. Over time, nursing research has expanded into a formal discipline, codified in practice acts and ethical codes, and it now serves as a foundation for evidence-based care. Every nurse is expected to integrate research into practice, even if not directly conducting studies. Evidence-based research is operationalized into evidence-based practice through a structured process that integrates scientific findings with clinical expertise and patient values. On the unit level, this may involve translating new guidelines into direct bedside practice, while at the organizational level, it requires collaboration with administrators and other stakeholders to align with institutional resources and values. Models such as the Johns Hopkins evidence-based practice model provide structured frameworks for implementing these changes. Evidence-based decision-making rests on the triad of patient preferences, clinical expertise, and the best available evidence. Balancing these three elements is often complex, as limitations in resources or institutional barriers may require modifications. In such cases, nurses adapt interventions without compromising patient safety. Clinical decision support tools such as checklists, bundles, and standardized care pathways have become widely used to ensure consistency and adherence to best practices. Bundles in particular, when applied in acute care and critical care environments, have demonstrated effectiveness in reducing complications such as ventilator-associated pneumonia and catheter-related bloodstream infections. Quality improvement is closely tied to research and evidence-based practice, as it provides a mechanism for evaluating and enhancing the care being delivered. QI must be ongoing, since even effective processes can be refined. Nurses contribute to quality improvement across all settings because of their direct involvement in patient care. QI projects not only improve outcomes, but also foster innovation, enhance professional growth, and optimize workflow efficiency. National programs such as the Joint Commission's accreditation standards, the Magnet Recognition Program, and the incorporation of QSEN competencies into nursing curricula provide structure and benchmarks for these efforts. Delegation is another critical responsibility for nurses, codified in state practice acts. The standards of delegation require adherence to the 5 rights: the right task, the right circumstances, the right person, the right communication, and the right supervision. Nurses must balance authority, responsibility, and accountability to ensure tasks are completed safely and appropriately. Effective delegation maintains patient safety while allowing nurses to focus on more complex aspects of care. Collaboration is an equally important standard, essential to modern interprofessional healthcare delivery. Nurses work alongside physicians, pharmacists, therapists, social workers, spiritual care providers, and other professionals, as well as patients and families themselves. Collaboration requires intentional effort, with emphasis on mutual respect, shared goals, and defined roles. The interprofessional education. Collaborative has outlined core competencies that prepare healthcare professionals for collaborative practice, including values and ethics, roles and responsibilities, communication, and teamwork. High-functioning teams demonstrate measurable improvements in patient outcomes, adherence to care plans, and overall quality of care. Effective teamwork is fostered by clear goals, strong communication, and ongoing interprofessional education. Leadership development tools, SMART goal frameworks, and structured teamwork programs, such as Team Steps. 3.0 provide practical strategies to strengthen team functioning. The respiratory system is organized from the upper airway through the lower airway into the lungs and ultimately to the capillary alveolar bed, where its primary function of gas exchange occurs. Each anatomical structure contributes to ventilation and perfusion, processes that must remain balanced to sustain life. At the alveolar capillary interface, oxygen diffuses into the blood, while carbon dioxide diffuses out, driven by partial pressure gradients. This exchange links directly to the cardiopulmonary system, where the lungs not only manage gas exchange but also contribute to the renin-angiotensin-aldosterone system, influencing blood pressure and fluid balance. Neurological control is essential, with the medulla oblongata and pons regulating the rhythm, depth, and length of respirations through opposing influences of the apneustic and pneumotaxic centers to maintain homeostasis. The cardiovascular system operates as a highly specialized pump and pipe network, consisting of the four-chambered muscular heart, circulating blood volume, and an extensive vascular system. Electrical conduction governs cardiac function, with impulses initiating atrial and ventricular contractions. A properly functioning electrical system produces efficient cardiac output, but disruptions can result in dysrhythmias, conduction blocks, or cardiac arrest. Normal physiology of this system was reviewed alongside the mechanisms that regulate cardiovascular function, underscoring its essential role in homeostasis. Because cardiovascular and respiratory functions are interdependent, impairment in one system frequently affects the other. Hypertension and arteriosclerosis can accelerate the development of coronary artery disease, while arrhythmias compromise perfusion and oxygen delivery. Dysfunction may present as minor asymptomatic abnormalities or escalate to life-threatening conditions such as respiratory failure or myocardial infarction. Risk factors are divided into non-modifiable elements like age, genetics, and sex, and modifiable factors such as smoking, poor diet, sedentary lifestyle, and stress. Healthy lifestyle decisions can slow or prevent the progression of disease, whereas negative behaviors often accelerate dysfunction. Comorbidities, including diabetes, obesity, or renal disease, compound risk and reduce resilience, influencing outcomes even when the primary cardiopulmonary diagnosis is managed. Diagnosis and monitoring rely on a combination of laboratory and bedside tools. Blood cultures identify infectious processes, while arterial blood gases provide data on oxygenation, ventilation, and acid-base balance. Pulse oximetry offers continuous, non-invasive monitoring of oxygen saturation, and capnography tracks exhaled carbon dioxide to assess ventilation. Pulmonary function testing provides detailed information on lung volumes and flow rates, but is often reserved for specialized pulmonary care. Electrocardiography remains essential for evaluating cardiac electrical activity, offering immediate insight into dysrhythmias, ischemia, or conduction abnormalities. Nursing care of patients with cardiopulmonary conditions spans outpatient, inpatient, and rehabilitative settings. Outpatient and home care focus on managing chronic conditions such as COPD or heart failure, while acute care addresses decompensation or emergencies. Rehabilitation supports recovery and maximizes function between exacerbations. Nurses must perform vigilant, frequent assessments because patient conditions can change rapidly. Preventing complications through measures such as pulmonary hygiene techniques helps maintain airway patency and prevent pneumonia. Pain and anxiety management are integral to supporting respiratory effort and cardiovascular stability. Care of cardiopulmonary patients is inherently interdisciplinary. Nurses coordinate with physicians, nurse practitioners, and physician assistants for decision-making and interventions, while respiratory therapists manage mechanical ventilation and assist with airway placement. Radiology contributes imaging to guide treatment, and specialized teams mobilize during cardiac or respiratory arrest to provide organized, time-sensitive care. Each discipline brings expertise that, when combined, enhances outcomes and ensures comprehensive support across the patient's course of illness and recovery. Nurses play a central role in this system, serving as continuous monitors, advocates, and collaborators to optimize patient safety and healing. The human body maintains internal stability through precise regulation of fluid, electrolytes, and acid-base balance. This regulation allows cellular processes to occur under stable conditions. Body fluid is distributed between two major compartments: the intracellular compartment, which contains about 2/3 of total body fluid, and the extracellular compartment, which contains about 1/3 of total body fluid. Extracellular compartment, which holds the remaining 1/3. Proper function depends on maintaining both the relative volume of these compartments and an overall balance, referred to as euvolemia. The extracellular and intracellular fluids differ in their electrolyte composition, and their concentrations are tightly controlled within narrow ranges. Small deviations can disrupt cellular metabolism, nerve transmission, and muscular activity, leading to significant health problems. Sodium, potassium, calcium, magnesium, chloride, bicarbonate, and phosphate are the key electrolytes that require close monitoring. Each plays distinct roles. Sodium is the primary extracellular cation, essential for water balance and nerve signaling. Potassium dominates inside cells and is crucial for cardiac and muscular function. Calcium and magnesium influence neuromuscular excitability and contraction. Chloride contributes to acid-base balance and osmotic pressure, while phosphate participates in energy metabolism and serves as a buffer. Bicarbonate is the primary extracellular base and is central to acid-base regulation. Electrolyte disturbances manifest in characteristic clinical signs. Elevated sodium, or hypernatremia, can cause mental confusion, irritability, and seizures, while low sodium, or hyponatremia, is associated with nausea, headache, and confusion. Potassium excess, or hyperkalemia, produces peak T waves on electrocardiography and predisposes to dangerous dysrhythmias. Potassium deficiency, or hypokalemia, is reflected by muscle weakness, lethargy, and changes in the electrocardiogram, such as flattened T waves, U waves, and prolonged ST segments. Calcium excess leads to nausea, vomiting, and generalized weakness, while calcium deficiency causes paresthesias and tetany. Chvostek's and Trousseau's signs are classic findings in hypocalcemia. Magnesium imbalance affects both cardiac and neuromuscular systems. Excess magnesium may cause bradycardia, muscle weakness, and tremors, whereas deficiency can present with vomiting, weakness, leg cramps, and dysrhythmias. The body relies on transport systems to regulate fluid and electrolyte movement between compartments. Passive transport moves water and solutes along concentration gradients and includes osmosis for water and diffusion for solutes. Active transport requires energy to move substances against their gradients, exemplified by the sodium-potassium pump, which exchanges intracellular sodium for extracellular potassium to maintain gradients essential for action potentials. Without this pump, sodium and potassium would equilibrate, preventing nerve and muscle conduction. Capillary filtration supplies tissues with oxygen and nutrients from arterial blood, while capillary reabsorption returns waste products to venous circulation. Acid-base balance is another critical element of homeostasis. Blood pH is normally maintained between 7.35 and 7.45. Values below this range indicate acidosis, and values above indicate alkalosis. These conditions are categorized by origin: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Effective regulation depends on chemical buffers, the respiratory system, and the renal system. Chemical buffers act quickly to stabilize pH by binding or releasing hydrogen ions. The carbonic acid bicarbonate system is the principal extracellular buffer, responsible for about half of the body's buffering capacity. Within cells, proteins and phosphates serve as major buffers. Proteins can accept or donate hydrogen ions because amino acids carry both positive and negative charges. The phosphate system relies on the interplay between dihydrogen phosphate, which neutralizes excess base, and hydrogen phosphate, which neutralizes excess acid. Beyond buffering, physiological systems provide sustained regulation. The respiratory system influences pH by controlling carbon dioxide excretion, because carbon dioxide combines with water to form carbonic acid. Altering its levels shifts blood pH. The renal system adjusts acid-base status by either excreting hydrogen ions or reabsorbing bicarbonate. The kidneys serve as the long-term regulators of acid-base balance, compensating for respiratory causes of imbalance, while the lungs can compensate for metabolic disturbances by altering ventilation. Nutrition is a cornerstone of health, supporting energy needs, growth, repair, and overall well-being. Adequate intake of macronutrients, carbohydrates, proteins, and fats ensures sufficient calories for daily metabolic demands, while water maintains fluid balance and micronutrients, such as vitamins and minerals, regulate critical cellular processes. Tracking weight and BMI provides valuable insight into nutritional trends and early risks. Nurses must understand nutrition across the lifespan to promote wellness, prevent disease, and optimize recovery. Nutritional status is shaped by both physiological and psychological factors. Physiological influences include age, sex, developmental stage, activity level, chronic illness, pregnancy, and lactation. Environmental and lifestyle factors such as socioeconomic status, access to food, and cultural habits also play major roles. Psychosocial factors add further complexity, as food often carries cultural or emotional meaning. While mealtimes may enhance social connection, they can also contribute to maladaptive behaviors such as emotional eating. Nurses must assess nutrition holistically, considering both biological and psychosocial dimensions. A healthy diet emphasizes balanced intake of macronutrients and micronutrients, coupled with food safety, label literacy, and strategies such as MyPlate guidelines. When health conditions demand, specialized diets are prescribed. For example, consistent carbohydrate diets for diabetes, low-sodium diets for hypertension, or high-protein diets for wound healing. Texture-modified diets, mechanical soft, pureed liquid, support patients with swallowing or digestion challenges. More complex interventions include enteral nutrition via NG, OG, or PEG tubes, and parenteral nutrition via PPN or TPN, which require precise nursing management to prevent complications and ensure adequate intake. Nutrition assessment combines subjective and objective data. History taking captures weight trends, eating patterns, medical history, and lifestyle behaviors, while objective measures include anthropometrics and focused physical findings. Laboratory values such as hemoglobin, hematocrit, WBC, albumin, prealbumin, and transferrin provide biochemical evidence of nutritional status. Integrating all data allows for accurate evaluation and individualized care planning. Numerous medical conditions disrupt nutrition, including infections, chronic inflammatory diseases, metabolic disorders, and eating disorders. Nurses must evaluate how these conditions and their treatments affect nutritional status. For eating disorders in particular, comprehensive care requires addressing both physical complications and underlying psychological stressors. Evidence-based interventions, patient education, and interprofessional collaboration are key to restoring nutritional balance and supporting long-term health. Activity, movement, and alignment are essential for health, requiring coordination between the skeletal, muscular, and nervous systems. Together, these systems support posture, circulation, coordination, and reflexes. Movement not only maintains musculoskeletal strength, but also promotes cardiovascular health and overall well-being. In healthcare, safe practices such as ergonomics and patient handling are critical to protecting both staff and patients. Proper body mechanics, including safe lifting and transferring, reduce injury risks. For patients, purposeful exercise enhances function and independence. Exercises may target flexibility, cardiovascular endurance, strength, or balance, each supporting different aspects of physical health. A person's ability to stay active can be influenced by multiple barriers. Physiological issues like pain, injury, or chronic illness, psychological challenges such as fear or anxiety, and external limitations such as environmental or financial constraints may all reduce physical activity. Nurses play a key role in assessing these barriers and helping patients find strategies to overcome them. Functional ability is often measured through activities of daily living, ADLS, which are divided into basic self-care tasks and more complex instrumental activities. Declines in activities of daily living may result from aging, illness, or cognitive decline, and are important indicators of patient needs. Assessment tools such as the CATS ADL Index, Lawton IADL Scale, and Barthel Index help guide care planning and determine levels of assistance, ranging from independent performance to full dependence on caregivers. Nurses support patients by promoting safe activity, maximizing independence, and tailoring care to each individual's functional abilities. The neuromuscular system represents the integration of the nervous system and the musculoskeletal system, functioning together to produce movement, maintain posture, and regulate vital processes. The nervous system consists of the brain, spinal cord, and peripheral nerves, all of which transmit electrical and chemical signals throughout the body. The musculoskeletal system is composed of bones, skeletal muscles, tendons, ligaments, and other connective tissues, serving as the structural and mechanical component that carries out movement. Communication between these two systems is achieved through motor neurons, transmitting impulses to muscle fibers, producing contraction and relaxation in response to both voluntary and involuntary stimuli. This coordination enables essential functions such as locomotion, postural stability, respiration through diaphragmatic and intercostal muscle control, and broader contributions to homeostasis by protecting the body against injury and maintaining functional equilibrium in changing environments. Evaluation of neuromuscular function requires diagnostic testing designed to identify or exclude specific disorders. Blood tests can reveal biochemical abnormalities, such as enzyme elevations associated with muscle damage or metabolic imbalances. Electromyography measures the electrical activity of muscle fibers in response to nerve stimulation, providing insight into the integrity of neuromuscular transmission. Nerve conduction velocity studies assess the speed and amplitude of electrical signals in peripheral nerves, helping to differentiate neuropathic from myopathic processes. Imaging studies, such as magnetic resonance imaging and computed tomography, are employed to visualize structural abnormalities in the brain, spinal cord, or musculature. Muscle biopsy allows direct microscopic examination of tissue for dystrophic, inflammatory, or metabolic changes. Genetic testing identifies inherited mutations responsible for many neuromuscular conditions. These modalities are frequently used in combination, as overlapping clinical presentations require systematic differentiation among numerous disorders. Neuromuscular diseases present with a broad spectrum of impairments, but often share common manifestations. Charcot-Marie tooth disease is a hereditary neuropathy leading to progressive distal weakness and sensory loss. Congenital myopathies present early in life with hypotonia and delayed motor milestones. Muscular dystrophies such as Duchenne and Becker involve progressive degeneration of muscle fibers with associated contractures and cardiopulmonary complications. Amyotrophic lateral sclerosis is a motor neuron disease characterized by relentless progression of muscle weakness, spasticity, and eventual respiratory failure. Multiple sclerosis involves demyelination within the central nervous system, producing fluctuating neurological deficits, including motor, sensory, and visual disturbances. Cerebral palsy is a non-progressive condition caused by early brain injury, resulting in motor impairment, spasticity, and postural challenges. Spinal cord injuries produce motor and sensory deficits determined by the level and completeness of the lesion. Despite differences in etiology and prognosis, these disorders often share features of muscle weakness, stiffness, atrophy, impaired coordination, pain, and difficulties with swallowing, breathing, and vision. Nursing care for patients with neuromuscular impairment must address complex physical and psychosocial needs. Respiratory function requires vigilant monitoring because weakness of the diaphragm and accessory muscles predisposes to hypoventilation, atelectasis, and infection. Interventions may include assisted coughing, suctioning, and mechanical ventilation in advanced stages. Mobility promotion focuses on maintaining joint range of motion, preventing contractures, and encouraging activity within patient tolerance through collaboration with physical therapy. Pain management requires individualized pharmacologic and non-pharmacologic strategies, as musculoskeletal pain and neuropathic pain frequently coexist. Adequate nutrition is essential, with attention to swallowing ability and metabolic demands. Dietitian involvement is often necessary for tailored meal planning or supplemental feeding. Elimination patterns must be assessed, as immobility contributes to constipation and urinary retention, while impaired skin integrity is a risk due to immobility and muscle wasting, necessitating frequent repositioning and skin inspection. Beyond physical considerations, nursing care also encompasses emotional and psychosocial support. Neuromuscular disorders are frequently chronic, progressive, and life-altering, contributing to anxiety, depression, and decreased quality of life. Nurses support coping and adaptation through therapeutic communication, counseling referrals, and encouragement of social support networks. Interdisciplinary collaboration enhances patient outcomes by involving specialists such as occupational therapists for adaptive equipment, speech therapists for communication and swallowing interventions, and social workers for resource coordination. Environmental modifications are critical to reducing fall and injury risk, including removal of obstacles, proper use of mobility aids, placement of bed alarms, and ensuring that beds remain in a low and locked position. The skin is composed of three primary layers: the epidermis, dermis, and hypodermis. The epidermis forms the outermost barrier and consists of stratified epithelial cells that provide protection from environmental exposures. The dermis, situated beneath the epidermis, contains elastic connective tissue, rich in collagen, supporting resilience and flexibility. The hypodermis, or subcutaneous tissue, anchors the skin to deeper structures while serving as insulation and energy storage. Collectively, the skin performs several critical functions, including protection from mechanical and microbial injury, thermoregulation through vasodilation, vasoconstriction, and sweating, sensory perception via specialized nerve endings, selective absorption, elimination of waste products, and the synthesis of vitamin D. The skin also plays psychosocial and cultural roles in identity, communication, and self-image. Assessment of skin must account for differences related to age, ethnicity, developmental stage, and cultural background to accurately distinguish normal variation from pathology. Normal healthy skin varies according to genetics, age, and health status. Factors that predispose individuals to impaired skin integrity include poor nutrition, inactivity, substance use, high-risk behaviors such as piercings and tattoos, and systemic illness or medications that compromise immunity or healing capacity. Genetic predispositions also contribute, as in conditions such as vitiligo, acne, psoriasis, eczema, and melanoma. Common disorders affecting the skin arise from infection, inflammation, or neoplastic changes. Bacterial conditions include impetigo, folliculitis, carbuncles, and cellulitis. Viral infections encompass herpes simplex, herpes zoster, and verrucae. Fungal infections often present as tinea, affecting regions such as the feet, scalp, groin, and body. Parasitic infestations include pediculosis and scabies. Inflammatory disorders encompass eczema, seborrheic dermatitis, urticaria, acne vulgaris, psoriasis, and systemic lupus erythematosus. Skin cancer occurs most commonly in the form of basal cell carcinoma, squamous cell carcinoma, and malignant melanoma, each with different degrees of aggressiveness and metastatic potential. Management of impaired skin integrity often requires both medical treatment and lifestyle modification, with nursing care focused on education, prevention, and promotion of long-term skin health. Wounds are classified by etiology and healing characteristics. They may be intentional, such as surgical incisions, or unintentional, resulting from trauma. They may be open, with breaks in the skin surface, or closed, with underlying damage but intact skin. Acute wounds progress through the normal healing cascade, whereas chronic wounds fail to follow the expected sequence and persist. Additional categories include pressure injuries and injuries due to friction or shear. Pressure injuries result from prolonged external pressure that impairs circulation and lymphatic flow, producing ischemia and tissue necrosis. Friction damages superficial layers of skin, while shear disrupts deeper structures by opposing forces that stretch and tear blood vessels. Together, these mechanical forces increase vulnerability to breakdown in immobile or debilitated patients. The risk of pressure injury development increases in the presence of moisture, malnutrition, immobility, and cognitive impairment. Moisture from incontinence or perspiration weakens the epidermis and allows microorganisms to proliferate. Malnutrition and dehydration compromise cellular repair, reduce perfusion, and eliminate protective subcutaneous padding. Immobility, particularly in bedridden patients, prevents redistribution of pressure, leading to ischemic damage over bony prominences. Cognitive deficits reduce awareness of discomfort and limit repositioning or help-seeking behaviors, further elevating risk. Pressure injuries are staged to standardize assessment and management. A Stage 1 injury presents as localized erythema of intact skin that does not blanch with pressure. Stage 2 involves partial thickness loss of the epidermis or dermis, appearing as an abrasion, blister, or shallow ulcer. Stage 3 reflects full thickness tissue loss, with visible adipose tissue and granulation, sometimes accompanied by slough or eschar. Stage 4 extends to underlying structures such as fascia, tendon, muscle, cartilage, or bone, frequently with necrosis, undermining, or tunneling. Deep tissue pressure injuries manifest as intact but discolored skin with maroon or purple hues, indicating underlying damage. Unstageable injuries cannot be classified due to extensive slough or eschar obscuring depth. Effective wound management requires an understanding of the physiology of healing. Wounds heal by primary intention when edges are approximated, secondary intention when left open to heal through granulation and contraction, or tertiary intention when initially left open and later closed. The phases of healing include hemostasis with clot formation, inflammation with phagocytic activity, proliferation with fibroblast and collagen deposition, and maturation with remodeling of scar tissue. Healing is influenced by local factors such as desiccation, maceration, trauma, edema, and infection, as well as systemic factors including advanced age, vascular insufficiency, hypoxia, obesity, diabetes, medication use, and lifestyle behaviors like smoking and alcohol consumption. Complications such as infection, hemorrhage, dehiscence, evisceration, and fistula formation significantly increase morbidity and healthcare burden. Wounds exert psychological as well as physical effects, altering body image, interfering with daily activities, and causing pain and anxiety. Nursing interventions are directed toward comprehensive management that includes assessment, documentation, proper positioning, dressing selection and application, drain and suture care, wound cleaning, and debridement when indicated. Additional therapies may include topical growth factors, heat or cold therapy, hyperbaric oxygen treatment, and surgical intervention. Nurses also play a central role in patient education, teaching strategies for wound care and self-management at home, while promoting health behaviors that support tissue integrity. Hygiene encompasses a range of practices designed to support health and prevent disease by maintaining cleanliness of the body. Care of the skin, hair, nails, oral cavity, and perineal areas forms the core of personal hygiene. Failure to uphold adequate hygiene can predispose individuals to numerous conditions, including lice infestations of the body, scalp, or pubic region, tooth decay, scabies, pinworm infections, fungal infections such as ringworm, bacterial eye infections such as trachoma, swimmer's ear, urinary tract infections, gingivitis, and periodontitis. The benefits of effective hygiene extend beyond infection prevention. Regular self-care contributes to both physical and psychological well-being, enhancing mood, reducing stress, improving self-esteem, supporting social relationships, and contributing to an overall sense of dignity and wellness. Personal hygiene is strongly shaped by cultural, socioeconomic, developmental, and individual factors. Cultural traditions influence how hygiene is practiced, from frequency and methods of bathing to the types of products used. Socioeconomic status affects hygiene through access to clean water, sanitation facilities, and hygiene products, with financial constraints often limiting these resources. Developmental stage determines both the need for and the ability to perform hygiene across the lifespan. Children may require assistance due to lack of coordination or understanding, while older adults may face physical limitations or chronic illness that hinder independence. Individual preferences also strongly influence hygiene routines, including choices related to bathing methods, hair length, nail care, and product selection. Physical health and mobility status are additional determinants, as conditions that limit movement or cause fatigue can impair hygiene practices. Psychological factors such as depression, cognitive impairment, or stress related to body image may reduce motivation or ability to maintain hygiene. For nurses, recognition of these influences is essential, and discussions about hygiene must be approached with sensitivity and without judgment, as hygiene behaviors may reflect not only personal choices, but also underlying health or psychological conditions. Nursing responsibilities in hygiene extend beyond basic assistance, requiring systematic assessment and individualized planning. The nurse must determine the patient's ability to perform self-care, the level of assistance required, and any barriers posed by physical or cognitive limitations. When delegating hygiene tasks, the nurse applies the 5 rights of delegation, ensuring the right task is assigned under the right circumstances to the right person, with clear instructions, appropriate communication, and supervision with follow-up evaluation. Hygiene interventions must always begin with a thorough assessment to detect lesions, infections, secretions, or abnormalities that may require further medical attention. Preservation of privacy and dignity during hygiene care is critical, achieved through a respectful professional approach. Specific areas of hygiene require specialized techniques. Oral care includes brushing of teeth, gums, tongue, cheeks, and palate, along with flossing and denture cleaning when applicable. Eyes, ears, and nose must be cleaned carefully to maintain sensory function, with consideration for devices such as eyeglasses, contact lenses, or hearing aids. Hair care varies according to patient preference and hair type, with attention to maintaining scalp health. Nail and foot care require caution, particularly in populations such as patients with diabetes, where improper trimming may lead to infection or ulceration. Perineal and vaginal care must be provided delicately to maintain cleanliness and prevent infections, while respecting patient comfort and modesty. Age-related changes introduce unique challenges for older adults, including decreased mobility, fragile skin, and altered oral mucous membranes, all of which increase the risk of impaired hygiene and secondary complications. Nurses must adapt hygiene interventions for these individuals, emphasizing preventive care, safe mobility assistance, and monitoring for breakdowns in skin or mucosal integrity. Health promotion through education is central to nursing care and hygiene. Nurses assess and reinforce patient knowledge, provide instruction in safe and effective techniques, and empower individuals to maintain or regain independence in hygiene tasks whenever possible. In this way, nursing practice ensures that hygiene contributes not only to disease prevention, but also to overall physical health, psychological stability, and quality of life. The urinary system consists of the kidneys, ureters, bladder, and urethra, working together to regulate internal balance through waste removal and fluid control. The kidneys function as highly specialized filters, with each nephron playing a role in the processes of glomerular filtration, tubular reabsorption, and tubular secretion. In glomerular filtration, water and solutes move from the blood into Bowman's capsule, creating an initial filtrate. Tubular reabsorption selectively returns essential substances such as glucose, electrolytes, and water back into circulation, while tubular secretion actively transports excess ions, metabolic byproducts, and drugs into the tubular fluid for elimination. Ureters carry urine to the bladder, which serves as a muscular reservoir, and the urethra provides the final passage for excretion. Urination is regulated through the micturition reflex, an interaction of the central and peripheral nervous systems, with muscular control of the bladder and urethral sphincters. The stages of filling, storage, and voiding require precise coordination. Dysfunction in this process can manifest as urinary retention, where the bladder fails to empty completely, or as incontinence, where voluntary control of urination is lost. These disturbances carry significant implications for health, independence, and quality of life. The urinary system eliminates nitrogenous wastes, including urea, creatinine, and uric acid, to maintain chemical equilibrium. Urea, formed during amino acid metabolism in the liver, is excreted to prevent toxic accumulation. Creatinine, generated in constant amounts by muscle metabolism, provides a reliable indicator of renal function, since it is almost entirely filtered by the kidneys. Uric acid, derived from purine breakdown, must be excreted to prevent crystal formation that may lead to gout or kidney stones. Through the regulation of these waste products, the urinary system plays a central role in maintaining biochemical stability. Kidneys are also essential for fluid, electrolyte, and acid-base balance. By adjusting reabsorption and secretion of sodium, potassium, chloride, and bicarbonate, the kidneys influence blood volume, blood pressure, and plasma osmolarity. Acid-base regulation is achieved by excreting hydrogen ions and conserving bicarbonate, maintaining systemic pH within a narrow range. Beyond filtration, kidneys act as endocrine organs. Renin secretion activates the renin-angiotensin-aldosterone system, leading to angiotensin II formation and vasoconstriction, with aldosterone promoting sodium and water retention to regulate blood pressure. Erythropoietin is released in response to hypoxia, stimulating bone marrow production of red blood cells and ensuring adequate oxygen transport. Urinary elimination is influenced by developmental, physiological, sociocultural, and psychological factors. Infants lack full bladder control until neuromuscular pathways mature, while children gradually acquire continence with growth. Older adults may experience weakened bladder contractility, decreased capacity, or reduced pelvic floor muscle tone. Sociocultural attitudes determine perceptions of continence and access to toileting facilities, while psychological stressors can interfere with reflex pathways and disrupt voiding patterns. Physiological conditions such as diabetes, kidney disease, or neurological impairment directly alter elimination, while medications may either enhance or impair urinary function. Assessment of urinary health involves a structured evaluation, incorporating medical history, physical examination, diagnostic tests, and patient-reported symptoms. Urinalysis provides essential information, with characteristics such as color, odor, clarity, volume, and specific gravity, serving as early indicators of underlying conditions. For example, dark concentrated urine may reflect dehydration, cloudy urine may indicate infection, and persistently high specific gravity may suggest impaired renal concentrating ability. Nurses must be attentive to these findings to detect and address urinary dysfunction promptly. Urinary retention assessment focuses on identifying incomplete bladder emptying. Palpation and percussion can detect bladder distension, while bladder ultrasound or catheterization measures post-void residual volume. Persistent retention may indicate obstruction, neurological dysfunction, or medication effects. Incontinence assessment requires evaluation of contributing factors, including stress incontinence caused by weakened pelvic floor muscles, urge incontinence from overactive detrusor activity, overflow incontinence due to obstruction, and functional incontinence resulting from cognitive or mobility limitations. Enuresis, or nighttime bedwetting, is assessed with consideration of developmental stage, behavioral patterns, and psychological stressors. Management of impaired elimination is multifaceted. Nurses implement interventions to protect skin integrity, as incontinence and retention can lead to irritation, breakdown, or infection. Repositioning supports circulation and prevents pressure-related complications, while bladder training programs use scheduled voiding and pelvic floor exercises to enhance control. Catheterization may be required when voluntary voiding is not possible, with careful adherence to a septic technique to reduce infection risk. Catheter irrigations help maintain patency and prevent obstruction, while regular monitoring ensures early recognition of complications. Additional strategies include patient education, fluid and dietary management, and collaboration with interdisciplinary teams to promote continence, comfort, and independence. And the gastrointestinal tract is a continuous system of organs designed to digest food, absorb nutrients, and eliminate waste. Ingestion begins in the mouth, where mastication and salivary enzymes initiate chemical and mechanical breakdown. The stomach continues this process through gastric acid, enzymes, and muscular contractions that produce chyme. The small intestine serves as the primary site of nutrient absorption, with villi and microvilli providing extensive surface area for transport of carbohydrates, proteins, fats, vitamins, and minerals into the bloodstream. The large intestine is responsible for absorbing water and electrolytes while compacting waste into feces. The rectum stores feces until elimination through the anus during defecation. Neural control is integral to bowel function. The parasympathetic division promotes peristalsis and sphincter relaxation, facilitating defecation, while sympathetic stimulation inhibits motility and contraction of the internal anal sphincter, slowing elimination. Through this coordination, the gastrointestinal tract ensures efficient nutrient uptake and waste removal, contributing to homeostasis. Bowel elimination is influenced by developmental, physiological, and lifestyle factors. Infants lack full control due to immature neuromuscular pathways, while older adults may experience diminished sphincter tone, decreased peristalsis, and reduced mobility, which predispose to constipation or incontinence. Daily bowel habits vary with fluid intake, dietary fiber, physical activity, and stress, each of which influences stool consistency and frequency. Medications significantly affect elimination, with opioids commonly slowing motility and predisposing to constipation, while antibiotics may disrupt intestinal flora and cause diarrhea. Awareness of these influences is essential for prevention and management of bowel irregularities in diverse patient populations. Evaluation of bowel function employs multiple diagnostic approaches. Serum laboratory studies assess electrolyte and fluid imbalances that may result from chronic diarrhea or vomiting. Stool tests evaluate for blood, pathogens, fat content, or occult disease. Breath testing identifies bacterial overgrowth and malabsorption syndromes. Genetic testing may detect hereditary gastrointestinal disorders such as familial adenomatous polyposis. Imaging, including plain radiographs, computed tomography, and magnetic resonance imaging, provides visualization of structural abnormalities, while endoscopic procedures such as colonoscopy and sigmoidoscopy allow direct mucosal inspection and biopsy. Laparoscopy permits visual evaluation of intra-abdominal pathology. Nurses contribute to diagnostic procedures through patient preparation, including bowel cleansing regimens, patient education, monitoring for complications, and recovery support. Constipation is a common disturbance of elimination defined by infrequent or difficult passage of stools, abdominal discomfort, bloating, and risk of complications such as fecal impaction. Management relies first on lifestyle measures, including increased dietary fiber, adequate hydration, and physical activity, followed by pharmacologic interventions such as stool softeners, osmotic agents, or stimulant laxatives when necessary. Diarrhea, the opposite disturbance, is characterized by rapid transit and frequent loose stools. Complications include dehydration, electrolyte loss, and nutritional deficits. Management emphasizes oral or intravenous rehydration, dietary modification to include easily digestible foods, and antidiarrheal medication in selected cases once infection has been ruled out or treated. Fecal incontinence, or loss of bowel control, manifests as involuntary leakage of stool, mucus, or gas. It often leads to social embarrassment, impaired quality of life, and skin irritation. Causes range from weakened pelvic floor muscles and neurological impairment to chronic diarrhea and structural damage. Management involves dietary regulation, pelvic floor strengthening exercises, pharmacological therapies, and skin protection. Advanced strategies include biofeedback training, sacral nerve stimulation, and surgical repair in cases of structural abnormality. Nursing interventions emphasize both physical management and psychosocial support, as coping with bowel disorders often involves significant emotional and lifestyle challenges. Sleep is a complex physiological process requiring coordination of neurological and physical systems, primarily regulated by the brainstem and influenced by circadian rhythms. Sleep occurs in cycles composed of 4 distinct stages, repeating every 90 to 110 minutes throughout the night. Stage 1 is the transition from wakefulness to sleep, typically occurring once at sleep onset, while subsequent stages cycle repeatedly until awakening. Across the lifespan, the structure, duration, and depth of sleep change. Neonates lacking established circadian rhythms may spend most of a 24-hour period asleep, while adults generally require 7 to 9 hours per night. The distribution of time spent in various sleep stages shifts with age, reflecting developmental changes in the nervous system and broader physiological needs. Multiple factors influence sleep quantity and quality. Physiological considerations include growth and development, illness, and the effects of medications. Lifestyle and habits exert significant impact. Physically inactive individuals often experience lower sleep quality, while regular exertion promotes physical fatigue, conducive to restorative rest. The consumption of stimulants such as caffeine and nicotine delays sleep onset and disrupts continuity, with nicotine producing some of the most pronounced disturbances. Alcohol, though initially sedating, impairs deeper stages of sleep, leading to fragmentation. Stress activates sympathetic responses that interfere with relaxation and sleep maintenance. Cultural patterns and personal routines further shape sleep behaviors. Disorders such as insomnia, parasomnias including sleepwalking or night terrors, and sleep-related breathing or movement disorders represent significant disruptions with broad health consequences. Insufficient sleep produces wide-ranging psychophysiological effects. In children, inadequate rest interferes with neurological development, learning, and behavior. Poor sleep is associated with difficulty concentrating, memory impairment, and reduced academic performance. It also contributes to emotional dysregulation and behavioral problems, while physiologically increasing risks for obesity and metabolic abnormalities. In adults, sleep deprivation is linked to impaired coping skills, mood disturbances, anxiety, and cognitive decline. Chronic sleep deficiency affects cardiovascular, gastrointestinal, metabolic, and immune function. These relationships are often bidirectional, as underlying medical conditions may contribute to disrupted sleep, while insufficient sleep exacerbates disease processes. Nursing practice plays a central role in identifying and addressing sleep disturbances. Assessment includes detailed health histories, review of sleep logs, and evaluation of the impact of inadequate rest on daily functioning and overall well-being. Nurses frequently begin by exploring sleep hygiene, including routines, environment, and behaviors that either support or impair sleep. Education regarding consistent sleep schedules, reduction of stimulants, incorporation of exercise, and management of stress are critical interventions. Pharmacological measures may be used when necessary, but nurses provide guidance on safe use, potential side effects, and interactions with other medications. Safety considerations are emphasized, particularly in populations vulnerable to nighttime falls or medication-related adverse effects. Sensory perception is the mechanism by which individuals gather, process, and interpret information from the environment through specialized sensory systems. Vision, hearing, touch, taste, and smell each provide unique inputs that allow humans to navigate and respond to their surroundings. Visual perception depends on the reception of light by the retina and subsequent processing by the visual cortex to interpret shapes, colors, and movement. Auditory perception begins with the conversion of sound waves into mechanical and electrical signals within the ear, which are then transmitted via neural pathways for interpretation as speech, music, or environmental sounds. Olfactory perception involves detection of airborne molecules by chemoreceptors in the nasal cavity, while gustatory perception depends on taste buds that identify sweet, sour, salty, bitter, and umami flavors. Tactile perception arises from mechanoreceptors in the skin that detect pressure, texture, vibration, and temperature, enabling protective reflexes and refined manipulation of objects. Beyond the 5 primary senses, kinesthetic receptors in muscles and joints provide feedback about body position and movement, while visceral sensory pathways monitor internal processes such as hunger, fullness, and pain, integrating physiological states with conscious awareness. The regulation of sensory input relies heavily on the reticular activating system located in the brainstem, which filters incoming stimuli and influences levels of wakefulness and attention. States of arousal range from full alertness and orientation to drowsiness, sleep, and coma, determined by neural activity and external stimulation. Adaptation allows sensory receptors to adjust to continuous or repetitive stimuli, reducing perception of irrelevant background input. Sensoristasis refers to the equilibrium at which sensory stimulation is neither deficient nor overwhelming, optimizing cognitive and emotional functioning. Conscious awareness reflects the integration of sensory information with thought and emotion, while unconscious states represent reduced responsiveness to external cues. Alterations in sensory function may occur when the balance of input is disrupted. Sensory overload results from excessive stimulation, producing irritability, anxiety, restlessness, and fatigue due to the inability of the nervous system to filter or prioritize signals effectively. Sensory deprivation, in contrast, results from a lack of adequate stimulation, which may lead to perceptual distortions, disorientation, and emotional distress. Both conditions compromise the ability to focus, problem solve, and maintain psychological stability. Sensory deficits such as vision or hearing loss, as well as sensory processing disorders, interfere with the brain's ability to interpret and respond appropriately to input, significantly affecting communication, learning, and social interaction. Multiple factors influence sensory perception. Physiological factors include developmental stage, age-related decline in sensory acuity, overall health status, and genetic predispositions to conditions such as congenital blindness or hereditary deafness. Psychosocial factors contribute to sensory experiences through mental health status, personality traits, coping mechanisms, and cultural norms that shape expectations and interpretations of sensory input. Medications can alter perception by depressing or stimulating the central nervous system, producing side effects such as blurred vision, tinnitus, altered taste, or changes in alertness. disorders of sensory processing, such as sensory modulation disorder, sensory-based motor disorder, and sensory discrimination disorder, represent disruptions in the integration of sensory information. These conditions impair the individual's ability to regulate, coordinate, and interpret stimuli, creating challenges in daily functioning, emotional regulation, and participation in social environments. Pain is a complex and multidimensional experience that requires systematic assessment to guide effective management. It can be classified based on duration, location, and underlying cause, with distinctions such as acute versus chronic, localized versus referred, and nociceptive versus neuropathic pain. The physiology of pain begins with nociceptors detecting noxious stimuli and transmitting signals through afferent nerve fibers to the spinal cord and brain, where the sensation is processed and interpreted. The brain does not merely register pain, but also modifies it through descending pathways that can inhibit or amplify nociceptive input. The gate control theory of pain illustrates this concept by proposing that neural mechanisms within the spinal cord regulate which signals reach the brain, accounting for variations in how pain is perceived under different conditions. Pain perception is influenced by biological, psychological, and social factors, making it inherently subjective. No two patients experience pain identically, and nursing practice emphasizes that pain is defined by the patient's report. Nurses must validate each patient's description and design individualized management strategies accordingly. Responses to pain arise through the autonomic nervous system and behavioral expression. The sympathetic system produces elevated heart rate, blood pressure, and respiratory rate, preparing the body for fight or flight, while the parasympathetic system can slow responses during prolonged or severe pain. Behavioral indicators include facial grimacing, guarding, withdrawal, or changes in mobility. Emotional manifestations such as fear, anxiety, and irritability often accompany pain and influence how patients express and cope with it. These responses vary widely, requiring nurses to be attentive to both subtle and overt cues. Psychosocial and physiological variables strongly shape pain experiences. Age and developmental stage alter both perception and expression of pain. Older adults may underreport pain or attribute it to aging, while children may lack the vocabulary to describe discomfort. Psychological attitudes also determine outcomes. Catastrophizing or anticipating failure of treatment can worsen pain perception, while positive expectations can improve response to therapy. Prior traumatic experiences, cultural norms, and personal coping styles further contribute to the complexity of pain management. Nurses play a role in educating patients about these influences, helping them recognize how mindset and external factors affect their experience and outcomes. A comprehensive pain assessment combines subjective and objective data. Subjective measures include the use of standardized pain scales, such as numerical, visual analog, or descriptive tools, along with open-ended questions that allow patients to describe the quality, timing, and impact of their pain. Objective measures include physical examination, monitoring of vital signs, and observation of nonverbal behaviors such as restlessness or altered posture. Both forms of data collection are necessary to build a complete picture. Timely assessment, intervention, and reevaluation are critical to ensure adequate relief, and meticulous documentation allows the healthcare team to track effectiveness and adjust treatment plans as needed. Pain management requires a multimodal and patient-centered approach that combines pharmacological and non-pharmacological strategies. Pharmacologic options include non-opioid analgesics, such as acetaminophen, and non-steroidal anti-inflammatory drugs, adjuvant medications such as anticonvulsants or antidepressants for neuropathic pain, and opioids for moderate to severe pain. Opioids carry significant risks of sedation, respiratory depression, tolerance, dependence, and overdose, necessitating cautious use and vigilant monitoring. Patient-controlled analgesia is an option that provides patients with autonomy in managing their pain, but requires education and monitoring to ensure safety. Non-pharmacological interventions are valuable both as adjuncts and as alternatives to medication. Techniques such as physical therapy, massage, relaxation exercises, guided imagery, cognitive behavioral strategies, distraction, and application of heat or cold can reduce pain intensity and improve coping. These methods avoid the adverse effects and risks associated with pharmacological therapy, making them especially important for long-term management. Nurses are responsible for evaluating which interventions are appropriate, educating patients about their options, and promoting active participation in care. Surgical procedures are categorized by urgency into emergent, urgent, expedited, and elective. Emergent surgeries are performed immediately to preserve life, prevent limb loss, or protect organ function. Urgent procedures are necessary for conditions that present sudden onset or deterioration with significant risk if delayed. Expedited surgeries are performed when the patient is stable, but requires early intervention before complications develop. Elective procedures are scheduled in advance, addressing conditions that do not directly threaten life or organ function. These classifications ensure prioritization of resources and patient safety in surgical care. Modern surgery has been transformed by technological advancements, including robotic-assisted techniques, telesurgery, artificial intelligence applications, enhanced endoscopic visualization, such as the multi-angle rear-viewing endoscopic tool, and the incorporation of three-dimensional printing for implants and surgical models. These innovations have expanded access, improved precision, and increased safety in many procedures, but they also introduce challenges related to cost, accessibility, and the potential for unforeseen risks. The nurse must be aware of these developments, as they influence patient education, surgical preparation, and post-operative care expectations. Anesthesia is a critical component of surgical care, with types including general anesthesia, monitored anesthesia care, or moderate sedation, regional anesthesia, and local anesthesia. Each has specific indications, benefits, and risks. General anesthesia provides complete unconsciousness and muscle relaxation, but carries risks such as respiratory depression and cardiovascular instability. Monitored anesthesia care allows sedation with varying depth while preserving protective reflexes. Regional anesthesia, including spinal, epidural, or nerve block techniques, numbs a large region of the body while the patient remains conscious. Local anesthesia targets a small area, often for minor procedures. Nurses play a central role in ensuring patients are evaluated appropriately, monitoring during recovery, and recognizing complications such as allergic reactions, malignant hyperthermia, or inadequate anesthesia depth. The preoperative stage focuses on preparing the patient holistically. The nurse performs thorough medical, surgical, and medication histories to identify risk factors, evaluates nutritional and psychological status, and reviews cultural or religious preferences that may affect care. Patient education includes fasting requirements, medication adjustments, and realistic expectations regarding postoperative pain and recovery. Informed consent, advance directives, and preoperative checklists are coordinated to ensure accuracy and safety. The nurse also prepares a comprehensive plan for pain management that incorporates both pharmacological and non-pharmacological strategies. Establishing rapport and reducing anxiety are essential as the nurse functions as a patient advocate during this vulnerable period. The intraoperative stage is where surgical interventions occur, requiring coordinated teamwork among surgeons, anesthesiologists, nurses, and technicians. Patient safety remains paramount, and perioperative nurses assume responsibility for protecting the patient when they are unable to advocate for themselves. This includes maintaining aseptic technique, verifying correct site and procedure, monitoring for positioning injuries, and remaining alert to complications such as intraoperative awareness, aspiration, and malignant hyperthermia. Effective communication and vigilance ensure that adverse events are recognized early and managed promptly, supporting successful outcomes. The postoperative stage encompasses immediate, intermediate, and convalescent phases of recovery. In the immediate postoperative period, patients are monitored in post-anesthesia care units, where nurses assess airway patency, vital signs, neurologic status, pain, and wound condition. Infection prevention, hemodynamic stability, and safe management of analgesics are priorities. Intermediate recovery focuses on promoting mobility, encouraging pulmonary hygiene, advancing diet, and managing drains, catheters, and surgical dressings. The convalescent stage emphasizes long-term healing, patient education, rehabilitation, and preparation for discharge. Throughout these phases, the nurse provides continuity of care, advocates for the patient, and ensures safe progression toward recovery. Special considerations are necessary for certain populations and procedures. Bariatric surgery patients require careful monitoring for respiratory compromise, altered pharmacokinetics of medications, and unique wound care needs. Pediatric patients may require developmental adjustments to pain management and communication, while geriatric patients are at higher risk for delirium, falls, and slower healing. Across all groups, discharge planning is essential to prepare patients and families for continued care at home, with clear instructions regarding medications, wound care, activity restrictions, and follow-up appointments. Self-concept is a multidimensional construct that develops throughout the lifespan and is shaped by both internal and external influences. Rogers emphasized that personal identity is formed through experiences, self-perception, and the evaluation of others. The primary elements of self-concept include personal identity, body image, self-esteem, and role performance, each of which interacts with developmental stages and life events. A positive self-concept enables realistic decision-making, effective coping, and resilience, while disruptions in self-concept can contribute to psychological distress or maladaptive behaviors. Clinical assessment of self-concept may employ a variety of validated tools and approaches, depending on the patient's situation, to ensure an accurate understanding of how the individual perceives themselves. Development of self-concept begins early in life. In Erikson's stage of toddlerhood, children establish autonomy and develop confidence in their capabilities. During elementary years, Self-concept is influenced by comparisons with peers, leading to either reinforcement of positive self-image or vulnerabilities related to self-esteem. Adolescence is a pivotal stage where identity formation occurs, as individuals internalize external messages about their strengths and weaknesses while simultaneously exploring independence and values. This process continues through adulthood and aging, with self-concept evolving in response to developmental changes, shifting social roles, and physical transformations. Multiple factors affect self-concept. Physiological influences such as illness, injury, or aging can significantly alter body image and perceived capabilities. Psychological experiences, including stress, trauma, grief, or success, contribute positively or negatively depending on context and coping resources. Personality traits shape whether individuals adopt optimistic or pessimistic perspectives. Cultural and societal influences, including media portrayals, social expectations, and peer feedback, play a central role in defining standards of attractiveness, competence, and success. Behavioral choices further reinforce or challenge self-concept through their impact on health, relationships, and performance in social roles. Each of these factors can alter self-esteem, self-image, and social identity, influencing overall self-concept across the lifespan. Sexuality is an integral part of health and self-concept, encompassing biological, psychological, social, and cultural dimensions. Biological sex refers to the classification assigned at birth, while gender identity reflects an individual's internal sense of self, which may or may not align with assigned sex. Social constructs of gender roles have historically dictated behaviors, but contemporary recognition of diverse gender identities and sexual orientations highlights the need for inclusivity in healthcare. Nurses must respect these variations, avoid bias, and provide individualized care that affirms each patient's identity and sexual health needs. Sexual fulfillment is an essential component of well-being, incorporating satisfaction, intimacy, and pleasure. Fulfillment may be achieved through physical stimulation, such as kissing, genital contact, or oral stimulation, and psychological stimulation, such as erotic media or auditory cues. Sexual behaviors can be adaptive or maladaptive. Adaptive behaviors promote well-being, mutual respect, and safety, emphasizing consent, communication, and safe sexual practices. Maladaptive behaviors, including compulsive pornography use, infidelity, or inappropriate touching, may compromise relationships, health, and psychosocial stability. Sexual expression is diverse and may include masturbation, intercourse, and other forms of stimulation, all of which carry distinct implications for health and risk management. Sexual health is influenced by physiological, psychological, and psychosocial factors. Developmental changes, chronic illnesses, and medications can impair sexual functioning, while psychological factors such as body image, stress, and mental health disorders may reduce desire or satisfaction. Cultural, religious, and lifestyle contexts shape beliefs and practices related to sexuality, affecting openness in discussing concerns and willingness to seek care. Ethical considerations underscore the importance of informed consent, respect for autonomy, and protection of individuals from coercion or harm in sexual activity. Nurses fulfill several roles in supporting sexual health. They provide education on prevention of sexually transmitted infections, pregnancy, and fertility. They model respect, self-awareness, and effective communication in addressing sensitive topics. They assess and recognize potential sexual health problems and refer patients for further care when necessary. As mandated reporters, nurses are legally required to report suspected sexual abuse or exploitation of vulnerable populations, including children, older adults, and individuals with disabilities. Stress is a multifaceted process involving perception of a threat and subsequent activation of physiological and psychological responses. The sympathetic nervous system mediates the acute response, releasing catecholamines that trigger the fight or flight reaction. This response increases heart rate, blood pressure, respiratory rate, and glucose availability, preparing the body for immediate action. In many cases, stress is adaptive, sustaining alertness and enabling effective responses to challenges. Stress also promotes growth and development by strengthening coping mechanisms, but when excessive or poorly managed, it contributes to maladaptation and disease. Adaptive responses return the body to homeostasis once the stressor has been managed. Effective coping strategies decrease sympathetic arousal and restore equilibrium, while maladaptive responses prolong activation of stress pathways, leading to chronic illness. Prolonged stimulation of the sympathetic system increases allostatic load, which refers to the cumulative physiological burden of stress over time. This chronic state predisposes individuals to cardiovascular disease, endocrine dysfunction, immune suppression, and impaired cognitive function. The balance between adaptation and maladaptation determines long-term health outcomes. Responses to stress vary across the lifespan. Developmental considerations influence how infants, children, adolescents, adults, and older adults perceive and respond to stressors. Infants rely on caregivers for regulation, while adolescents experience stress related to identity formation and social pressures. Adults encounter stress from work, relationships, and financial responsibilities, while older adults face stressors related to health decline and loss. Resilience, optimism, and prior experiences influence the effectiveness of adaptation. Individuals with strong coping skills and supportive environments return to homeostasis more effectively than those who have experienced trauma or lack resilience. The body maintains homeostasis through both localized and systemic stress responses. Local adaptation syndromes include reflex responses and inflammation, which protect tissues and promote healing. The general adaptation syndrome, described by Seeley, consists of alarm, resistance, and exhaustion stages. The alarm stage initiates the fight or flight reaction. The resistance stage involves sustained activation to counteract the stressor. If stress persists without resolution, exhaustion occurs, leading to decreased reserves and potential system failure. Psychosocial homeostasis integrates mental, emotional, and social factors, emphasizing the interdependence of mind and body in responding to stress. Stress impacts all levels of Maslow's hierarchy of needs. Physiological stress threatens basic survival needs, such as oxygenation and nutrition, while safety, belonging, self-esteem, and self-actualization can be disrupted by chronic or overwhelming stressors. The immune system is particularly vulnerable, with stress decreasing resistance to infection and delaying wound healing. Nurses frequently encounter stress-related disorders such as anxiety, depression, hypertension, and gastrointestinal disturbances in clinical practice. Crisis occurs when adaptive responses fail to restore equilibrium. During a crisis, psychological homeostasis is lost, and the individual cannot cope effectively. Crises may be maturational, situational, or adventitious. Maturational crises arise during normal developmental transitions such as adolescence or retirement. Situational crises result from unexpected events like job loss or illness. Adventitious crises stem from disasters or traumatic events. When coping resources are overwhelmed, stress escalates to crisis, requiring professional intervention. Socioeconomic factors heavily influence stress and adaptation. Beyond financial resources, access to health care, supportive communities, and safe environments determine resilience and outcomes. Individuals with robust social networks, spiritual support, and access to care are more likely to adapt effectively. Conversely, limited resources increase vulnerability to maladaptive responses and chronic stress-related illness. Theories of stress provide frameworks for understanding its impact. Selye's general adaptation syndrome emphasized physiological responses, while more recent concepts of allostasis and allostatic load highlight the body's ability to adapt to stress and the costs of maintaining adaptation under chronic conditions. Roy's adaptation model expands on these concepts, presenting a holistic nursing framework that integrates physiological, psychological, and social responses. The psychoneuroimmunological stress model emphasizes the bidirectional relationship between psychological and physiological processes, illustrating how anxiety and mental distress can trigger physical responses, and how physiological illness can generate psychological stress. Coping strategies are essential mechanisms of adaptation. Effective coping involves identifying stressors, assessing available resources, prioritizing responses, implementing actions, and evaluating outcomes. Strategies may be problem-focused, addressing the source of stress, or emotion-focused, aimed at managing the emotional impact. Maladaptive coping such as avoidance, denial, or substance use perpetuates stress and contributes to illness. Grief, loss, and death are universal human experiences that nurses encounter in every area of practice. Loss is the foundation of grief and can be actual, such as the death of a loved one, or perceived, involving a loss of status, independence, or role. Loss may also be anticipatory, as in the expected death of a terminally ill patient, maturational, such as the changes that occur with aging, or situational, such as sudden illness or trauma. Regardless of type, the patient's response to loss is unique and shaped by personal values, cultural beliefs, prior experiences, and available support systems. Grief itself is a natural but complex reaction to loss, encompassing physical, emotional, cognitive, behavioral, and social dimensions. Bereavement refers to the state of having lost someone, while mourning is the outward expression of grief, both of which are shaped by cultural and societal practices. Physical symptoms of grief often overlap with emotional and psychological manifestations. Patients may experience palpitations, headaches, gastrointestinal upset, dizziness, or fatigue, while simultaneously struggling with anxiety, anger, depression, or guilt. These symptoms influence social interactions, often straining family and community relationships during a vulnerable time. Theories such as George Engel's stages of grief and Elizabeth Kubler-Ross's 5 stages, denial, anger, bargaining, depression, and acceptance, offer frameworks for understanding, though individual experiences rarely follow a linear path. Nurses must recognize these patterns without rigid expectations, maintaining a non-judgmental approach that validates the uniqueness of each patient's grief response. Understanding the physiological and psychological processes of dying allows nurses to provide compassionate and informed care. The dying process includes progressive changes in circulation, respiration, digestion, cognition, and elimination. Nurses anticipate these changes and provide education to families, helping them prepare for alterations in appearance, responsiveness, and function as death approaches. Anticipatory guidance reduces fear and fosters peace for families as they witness their loved ones decline. Interdisciplinary collaboration is essential, with nurses working alongside physicians, social workers, chaplains, and palliative care specialists to provide holistic support. Care at the end of life focuses on comfort, dignity, and quality of life. Palliative care addresses pain and symptom management, while hospice services provide comprehensive physical, emotional, and psychosocial care for patients and families nearing the end of life. Comfort measures include medication management, repositioning, hygiene, and emotional support, as well as spiritual care according to patient and family preferences. The nurse functions as both advocate and caregiver, ensuring that interventions align with the patient's wishes and advanced directives. The experience of death and grief is influenced by multiple factors, including the timing and type of death. Sudden deaths, such as those caused by accidents, suicide, or homicide, often produce shock, disbelief, and complicated grief, while anticipated deaths may allow for gradual adjustment, but still generate profound sorrow. Death by suicide is particularly difficult, often accompanied by guilt, shame, and stigma among surviving family members. Age and maturity also shape perceptions of death, with children, adolescents, and adults processing grief differently. Nurses must be sensitive to cultural differences in rituals, mourning practices, and expressions of grief, providing culturally competent care that respects traditions and beliefs. Legal and ethical considerations are integral to end-of-life care. Nurses must understand the implications of advance directives, physician orders for life-sustaining treatment, do not resuscitate orders, and the legal frameworks governing practices such as euthanasia, provider-assisted death, and terminal weaning. Ethical care emphasizes respect for autonomy, beneficence, and dignity, while balancing professional, cultural, and legal standards. Nurses play a central role in supporting patients and families through these decisions, providing information, advocating for patient wishes, and facilitating communication among the healthcare team. After-death care involves both the patient and the family. Postmortem care includes maintaining dignity of the deceased, respecting cultural and religious practices, preparing the body for viewing, and providing a calm environment for families to begin mourning. Nurses may also assist with organ donation processes, consent for autopsy, and coordination with funeral services. Compassionate communication and presence during this stage are vital, as families often remember these moments with lasting clarity. Growth and development across the human lifespan provide the framework for understanding patient needs and delivering effective nursing care. Physical growth, such as changes in height, weight, and organ maturation, is more straightforward to measure, but it must always be assessed alongside development in areas including cognition, psychosocial adaptation, personality, communication, sexuality, and motor skills. These domains are interdependent, and disturbances in one area can influence others. Development is typically organized into distinct stages, beginning with the newborn period from birth to 28 days, followed by infancy through 12 months, toddlerhood from 1 to 3 years, preschool years from 3 to 5 years, middle childhood between 6 and 11 years, adolescence from 12 to 17 years, young adulthood from 18 to 35 years, adulthood from 36 to 64 years, and older adulthood at 65 years and beyond. Each stage carries its own milestones, challenges, and vulnerabilities, and nursing care must be tailored accordingly to address immediate concerns while anticipating long-term outcomes. Play is considered a central mechanism of growth, particularly in childhood, but its significance extends across the lifespan. It serves as both a developmental task and a therapeutic outlet, fostering physical coordination, social skills, emotional resilience, and cognitive problem-solving. The form of play evolves with age. Solitary play characterizes early childhood, while associative play involves interaction without formal organization. Cooperative play introduces shared goals and rules, and onlooker play reflects observation and engagement through imitation or curiosity. For children, play is often described as their primary occupation, but even adults and older adults engage in analogous activities that serve to maintain mental health, social connection, and physical well-being. Theories of development provide structured frameworks that inform nursing assessments and interventions. Erik Erikson's psychosocial theory describes 8 stages across the lifespan, each defined by a central conflict, such as trust versus mistrust in infancy, or identity versus role confusion in adolescence. Jean Piaget's theory of cognitive development outlines 4 sequential stages: sensorimotor, preoperational, concrete operational, and formal operational, emphasizing the ways children learn to reason and solve problems. Lawrence Kohlberg extended Piaget's work by proposing stages of moral development, from obedience-driven reasoning in childhood to principled decision-making in adulthood. Sigmund Freud, though less directly applied in modern nursing practice, established psychosexual stages that influenced later theories, focusing on how early experiences shape personality and behavior. Together, these theories equip nurses with a developmental lens through which to interpret patient behavior, needs, and potential risks. Effective nursing care requires integrating growth and development knowledge into clinical decision-making. A patient's developmental stage affects health status, coping mechanisms, family dynamics, and available support systems. For example, pediatric patients require assessment of milestone attainment, while older adults may require evaluation for cognitive decline or loss of functional independence. Family and caregiver resources must also be considered, as these significantly influence recovery and adherence to treatment plans. Well visits provide structured opportunities to evaluate these dimensions outside of acute illness, focusing on prevention, education, and early detection of long-term complications. Pediatric well visits occur at frequent intervals to monitor rapid developmental changes, while visits for adults often emphasize chronic disease screening, preventive counseling, and health promotion. Vaccinations are a critical component of preventive care throughout the lifespan. They provide acquired active immunity by exposing the immune system to antigens, prompting the creation of antibodies and memory cells capable of mounting a rapid response to future exposures. This process not only protects individuals, but also contributes to herd immunity, reducing disease transmission in the wider population. Nurses play an essential role in vaccination programs by educating patients and caregivers about the benefits, risks, and expected outcomes of immunization. They must be prepared to address misconceptions, manage vaccine hesitancy, and explain both individual and public health implications. Additionally, nurses are responsible for the safe administration of vaccines, monitoring for adverse reactions, and documenting immunization status as part of the patient's medical record. Growth and development begin at conception, when genetic material determines the basic structure and potential of the child. During the prenatal period, organ systems are formed, and intrauterine exposures influence long-term health outcomes. After birth, the neonatal stage is marked by adaptation to life outside the womb, including bonding with caregivers, regulation of temperature, and feeding. Infancy is characterized by rapid physical growth and neurological development, with milestones such as head control, rolling, sitting, and eventually walking. Cognitive and language development accelerate, and infants rely completely on caregivers for survival, making this period especially vulnerable to neglect or unsafe conditions. The toddler stage introduces slower physical growth, but rapid expansion of gross motor abilities, language, and social independence. A central feature of toddlerhood is the development of autonomy, often expressed through resistance to parental control. Preschool children refine fine motor skills, develop more complex communication, and learn to function within group settings. In the school-age years, growth continues at a steady pace, and children place increasing importance on peer relationships and activities. Adolescence, beginning around age 12, introduces rapid growth spurts, sexual maturation, and the challenge of forming a personal identity distinct from family influence. This final stage of child development involves navigating social pressures, cognitive advances, and emotional volatility as individuals transition toward adult roles. Several developmental theories frame these stages. Freud's psychosexual theory emphasizes progression through sequential stages driven by the pursuit of pleasure. Unresolved conflicts in these stages may result in maladaptive patterns later in life. Erikson extended these ideas into psychosocial stages, each characterized by a central conflict, such as trust versus mistrust in infancy, or identity versus role confusion in adolescence. Failure to resolve these conflicts may impair emotional health or social functioning. Havighurst offered a task-oriented perspective, identifying developmental tasks that must be mastered at specific ages. These tasks do not center on conflict, but on acquiring skills and abilities that contribute to personal competence and life satisfaction. Together, these theories guide nurses in anticipating developmental needs and potential vulnerabilities at each age. Health risks evolve alongside developmental stages. For women of childbearing age, risks are linked to fertility, pregnancy maintenance, and fetal health. Preconception health, maternal nutrition, and chronic condition management influence the course of pregnancy. During the prenatal period, risks include congenital malformations, teratogenic exposures, and complications of labor and delivery. Neonates face risks of birth trauma, prematurity, and sudden infant death syndrome, necessitating careful caregiver education about safe sleep and early bonding. Infants, completely dependent on caregivers, are susceptible to neglect, failure to thrive, and accidental injury. In the toddler years, mobility and curiosity increase risk for accidents, while challenges around discipline and milestones, such as toilet training, can escalate parental frustration, raising concerns for abuse. Nutritional risks also emerge when transitioning to solid foods and cow's milk, underscoring the need for parental guidance in maintaining a balanced diet. Preschool children experience frequent exposure to peers, increasing risks of communicable disease and accidents. In the school-age years, risks expand to include bullying, school violence, and the manifestation of learning disabilities. Adolescents encounter health risks tied to identity formation, including risk-taking behaviors, mental health disorders, substance use, and unsafe sexual activity. Peer influence becomes particularly strong, and inadequate coping strategies may result in anxiety, depression, or self-harm. Nursing considerations mirror these evolving risks. During the prenatal period, nurses provide education on family planning, maternal health, and strategies for minimizing adverse pregnancy outcomes. In the neonatal and infant stages, guidance emphasizes feeding, safe sleep practices, and caregiver support. As toddlers develop independence, anticipatory guidance helps parents balance supervision with fostering autonomy and encouraging language development. For preschoolers, nurses emphasize safety in group settings, promoting early learning, and guiding parents as children navigate socialization. In the school-age years, the focus shifts toward identifying learning difficulties, addressing bullying, and supporting increasing independence. Nurses and parents should collaborate to monitor academic progress and intervene when disabilities are suspected. In adolescence, nursing care emphasizes open communication, supporting mental health, and helping teens explore identity formation. Risk-taking behaviors must be addressed directly, with education on substance use, sexual health, and coping strategies. Parents benefit from resources and support to manage these challenges while maintaining open lines of communication with their children. The adult stage of the lifespan spans from age 18 to 64 and is marked by significant physiological, psychological, and psychosocial change. While broad developmental patterns exist, there is considerable variation, and nurses must approach adult care with flexibility and an individualized focus. In young adulthood, physical health often peaks, supported by high levels of strength, reproductive capacity, and cognitive efficiency. At the same time, the brain continues to mature, especially in areas related to decision-making and impulse control. Psychological changes in this stage include increased independence, the establishment of long-term relationships, and the restructuring of social networks. Lifestyle choices made during young adulthood carry long-term consequences, as behaviors related to diet, exercise, sleep, alcohol consumption, and tobacco use shape the risk for cardiovascular disease, diabetes, cancers, and mental health conditions later in life. Middle adulthood brings a range of physical and physiological changes that reflect both natural aging processes and the cumulative effects of lifestyle and heredity. The skin loses elasticity, bone and muscle mass decline, and urinary function may become less efficient. Women experience menopause, which has both physical and emotional consequences, while men may face gradual changes in reproductive hormones. Atherosclerosis and other chronic conditions often begin to manifest, placing adults at greater risk for heart disease, stroke, and metabolic syndromes. These changes are strongly influenced by prior health behaviors, making preventive interventions and lifestyle modifications particularly important in this stage of life. Developmental theories provide a framework for understanding these transitions. Erikson identified intimacy versus isolation as the key conflict of young adulthood, followed by generativity versus stagnation in middle adulthood. Successful resolution of intimacy involves the ability to form deep, committed relationships, while generativity emphasizes productivity, parenting, and contributions to society. Levinson's theory of adult development highlights the importance of life structures and transitions, suggesting that adults periodically reassess goals and roles. Valent's perspective expands on Erikson, stressing adaptive mechanisms that promote psychological resilience and satisfaction. Neugarten's theory, particularly the concept of the social clock, emphasizes the influence of cultural expectations and timing of life events, which may create stress if an individual's life course diverges from societal norms. Keegan's constructive developmental theory considers how adults make meaning of their experiences, shaping how they view health, relationships, and personal growth. Together, these models help nurses identify where patients may be struggling and provide care that aligns with developmental needs and values. Health risks in adulthood can be grouped into physiological, psychological, and psychosocial domains, though these categories often overlap. Physiological risks increase as individuals move from young adulthood into middle age and may include obesity, hypertension, diabetes, heart disease, and cancers. Psychological risks such as depression and anxiety are present throughout adulthood, often triggered by stressors including work, financial instability, or family dynamics. These psychological risks can amplify physiological conditions, for example, when depression contributes to poor self-care or substance misuse. Psychosocial risks involve injuries from accidents, workplace violence, or interpersonal violence, as well as substance abuse and addiction. Interpersonal violence is a significant concern, with implications for both physical safety and mental well-being. Each of these categories influences the others, requiring nurses to approach risk in a comprehensive and interconnected manner. Assessment and prevention are central to nursing care in this population. Screening for chronic diseases, metabolic disorders, and cancers should be incorporated into routine care, alongside regular mental health assessments using standardized tools, such as the Patient Health Questionnaire 9 or PHQ-9 for depression. Nurses are also positioned to identify substance use disorders early and provide education, referrals, and support to mitigate long-term consequences. Health promotion strategies in adulthood focus on fostering healthy behaviors such as balanced nutrition, physical activity, stress management, and adherence to screening recommendations. Because prevention is more effective and less costly than treatment, the nurse's role in motivating patients and reinforcing the importance of wellness behaviors is vital. Nursing care in adulthood also relies heavily on interdisciplinary collaboration. Referrals to medical specialists are often necessary for complex conditions, and nurses facilitate these transitions by educating patients and coordinating care. For example, patients with diabetes may be referred to certified diabetes educators, while those with cancer may require specialized oncology services. Social workers may be involved to provide resources for financial assistance, family support, or long-term care planning. Nurses frequently serve as the central point of coordination, identifying needs, mobilizing the appropriate team members, and ensuring continuity of care. Older adulthood, defined as age 65 and older, is a stage marked by wide variation in health status, functional ability, and social roles. While some older adults remain highly independent and active, others experience significant limitations due to chronic illness, cognitive decline, or environmental barriers. Nurses must understand these differences and approach care with individualized strategies that address the unique physiological, psychological, and psychosocial changes of aging. Developmental changes are expected but not universal, and the nurse's role includes distinguishing between normal aging processes and pathological conditions that require intervention. Physiological changes in older adulthood affect every organ system and contribute to increased vulnerability to illness and injury. Decreased skin elasticity, reduced bone density, sarcopenia, and diminished balance increase the risk of falls and fractures. Cardiovascular changes such as decreased vessel elasticity and impaired baroreceptor sensitivity contribute to hypertension and orthostatic hypotension. Respiratory function declines due to decreased lung elasticity and weakened respiratory muscles, raising susceptibility to infection and chronic obstructive pulmonary disease. Renal function gradually diminishes, altering drug metabolism and increasing risk for medication toxicity. Sensory impairments such as hearing and vision loss can reduce independence and complicate communication, while changes in the gastrointestinal system may contribute to malnutrition and weight loss. Nurses must remain alert for these systemic changes, monitor closely for complications, and adapt interventions to preserve function and prevent further decline. Psychological health in older adulthood is influenced by both biological and environmental factors. Cognitive decline can range from mild forgetfulness associated with normal aging to progressive conditions such as dementia and Alzheimer's disease. Nurses must differentiate between reversible causes of acute confusion, such as delirium, and chronic degenerative processes. Tools for mental health screening allow early recognition of depression, anxiety, or grief, all of which are common in this population. Emotional health may be strained by loss of independence, bereavement, or social isolation. Recognizing these psychological risks is essential to preventing declines in overall functional ability, as mental and physical health are closely interconnected in older adults. Psychosocial changes are equally significant and often compound physiological or psychological vulnerabilities. Retirement may alter identity and reduce opportunities for social interaction. Loss of a spouse, family members, or peers can lead to loneliness and isolation. Relocation to assisted living or long-term care facilities introduces stress as individuals adapt to new environments and routines. Older adults may also face reduced access to transportation, financial insecurity, and health disparities that affect their quality of life. Abuse and neglect, whether physical, emotional, or financial, remain serious risks, and nurses are obligated to recognize signs and advocate for protection. By fostering coping skills and supporting social engagement, nurses can help mitigate psychosocial risks and promote resilience in this stage of life. Theories of aging provide valuable guidance for nursing practice. Erikson's psychosocial theory frames older adulthood as a stage of integrity versus despair, where individuals reflect on life achievements and losses. A sense of integrity brings acceptance and fulfillment, while despair arises from regret or fear of death. Maslow's hierarchy of needs supports prioritizing physiological, safety, social, esteem, and self-actualization needs in individualized care plans. Havighurst's activity theory emphasizes continued engagement in meaningful activities to maintain health and well-being, while also recognizing that the level and type of activity must be tailored to each person's abilities. These theories equip nurses to challenge stereotypes about aging and design interventions that address both limitations and strengths. Health risks in older adults are commonly divided into physiological, psychological, and psychosocial domains, but these overlap significantly. Functional decline, malnutrition, and mobility impairment fall under physiological risks, but directly influence psychosocial independence and psychological stability. Cognitive impairment is categorized as psychological, but has physiological underpinnings and psychosocial consequences. Depression, grief, and loneliness represent psychological and social challenges that also increase susceptibility to physical illness. Nurses must approach these risks holistically, with assessment tools and strategies that capture the full spectrum of patient needs. Preventive measures such as fall risk assessments, nutritional evaluations, cognitive screenings, and depression monitoring allow for early intervention. Nursing care for older adults occurs across primary care, specialty clinics, home health, and long-term care facilities. In every setting, the nurse's central responsibility is promoting illness prevention and wellness maintenance. This includes following current guidelines for health screenings, such as cancer checks, cardiovascular assessments, and immunizations. Functional and comprehensive health assessments help identify risks early and guide individualized care planning. Interdisciplinary collaboration strengthens care delivery with physicians, physical and occupational therapists, pharmacists, speech therapists, and mental health professionals contributing expertise. Nurses also work with social workers, chaplains, and counselors to ensure patients have access to both medical and supportive resources. The terms disability and impairment are often used interchangeably. However, most definitions explain impairments as physical or mental deficits or differences that can be seen or perceived. Disability relates to how impairments affect an individual's ability to function in their home and community environment. Physical, cognitive, and congenital impairments often result in disabilities. Disabilities are the consequence of impairments that limit the ability of individuals to perform physical actions, cognitive processes, learning tasks, or communication in expected ways. Physical disabilities may arise at birth, develop over time, or occur as a result to an acute injury. Cognitive, intellectual, developmental, and psychiatric impairments result in a wide variety of disabilities. Disabilities are common at all ages, but the type of disability varies during the lifespan. Although congenital and developmental disabilities are often diagnosed in childhood, the effects of these disabilities on functioning persist throughout an individual's life. Older adults commonly develop disability related to mobility and sensory changes associated with disease and the aging process. These disabilities affect an individual's daily functioning at home, school, and in the wider community. Disabilities can be congenital, progressive, or acquired, and a person's response to disability depends on factors such as the severity of the disability, available support, and grief response. Models of disability are essential for framing patient-centered care planning and creating an awareness of how healthcare professionals and the broader community view disability. These models relate to the morals, medical care, social interactions, functional abilities, rehabilitation, social and biopsychosocial aspects of caring for individuals with disabilities. Although each model can be understood independently, understanding the interplay between these concepts is key to providing individualized care. Individuals with disabilities experience a wide range of barriers, from physical difficulty accessing a building to the inability to communicate effectively with their healthcare provider. By recognizing barriers, nurses can eliminate physical obstacles and social bias in their care setting. Helping individuals access affordable care, navigate insurance requirements, and feel accepted and included are all ways that nurses can ensure quality health care for people with disabilities. Chronic conditions are prevalent in our society. The most prevalent chronic diseases in the United States are CVD, 50%, obesity, 42%, and arthritis, 25%. Other prevalent chronic diseases include diabetes, cancer, epilepsy, and pain. Chronic diseases encompass many disorders that can be identified by specific medical criteria. Chronic illness, on the other hand, describes the patient's experience with a chronic condition, including symptoms, time frame, and treatment responses. It is also common for individuals to have multiple chronic conditions simultaneously. Often, symptoms may overlap, and different disorders may contribute to the development of other chronic conditions. Chronic conditions can develop in any organ system, ranging in severity from mild to life-threatening. Chronic conditions last longer than 1 year and typically have ongoing symptoms that require continued medical monitoring or treatment. Chronic conditions may be genetic or acquired and may progress and change over a person's lifespan. The majority of the acquired chronic conditions, such as heart disease, type 2 diabetes, obesity, and high blood pressure, are associated with a very short list of risk factors: smoking, excessive alcohol use, and a sedentary lifestyle. Recognizing symptoms of common conditions is crucial for nurses in day-to-day practice. Awareness of rare disorders will improve the nurse's ability to identify concerning symptoms early in the course of the disease. Nurses must consider many aspects of an individual's circumstances when caring for chronic conditions. Keeping in mind ethical considerations is crucial for providing patient-centered care. At-risk populations include pregnant women, children, older adults, and those with housing instability. These individuals may require more creative and individualized care based on their specific support needs. All individuals experience the effects of social factors, financial status, and environmental circumstances. These factors directly affect outcomes related to chronic conditions. Nurses must always consider family dynamics during patient care and include family in care, planning if appropriate and preferred by the patient. Physical and functional assessments set the stage for nursing interventions focused on chronic disease management. Assessments may be head-to-toe or focused on specific concerns. These assessments must occur periodically to monitor for change over time. Education about therapies, medications, progression, and expectations is an ongoing process in chronic disease care. Nurses will also collaborate with other healthcare providers and ancillary specialties in providing supportive care. Supportive care addresses disease management and symptoms and consequences of the disease process.